We'll get started. Welcome, everyone. Welcome to the 10th annual Young-Onset and Hereditary Colorectal Cancer Education Day, done by the Cleveland Clinic Center for Young-Onset Colorectal Cancer and the Weiss Center for Hereditary Colorectal Neoplasia. So just very briefly, I don't want to take up any time because we have a very full agenda, but just very briefly about the Weiss Center. So the Weiss Center houses our hereditary registry, and the hereditary registry was started in 1979. So it goes back quite some time, and we have the privilege of taking care of many, many patients with hereditary colorectal conditions. What's important to know about hereditary conditions, because a lot of patients and families who deal with it might not know it, is that they are quite rare. Even though we see many such patients at the Cleveland Clinic, it's a rare condition. While colorectal cancer in itself is quite common, hereditary conditions are rare, with less than 5% of all colon cancers being hereditary. And therefore, there aren't many physicians and caregivers who are familiar with these conditions and often don't know exactly what needs to be done. And that can be daunting to patients, especially if they are being taken care of by somebody who might not know exactly what they're dealing with. Now, young-onset colorectal cancer, we started our center several years ago. So many patients with hereditary cancers do have the risk or develop cancer at a young age. That's one of the hallmarks of hereditary cancers. So similarly, young-onset cancer, because colon cancer traditionally has been thought of as a disease that mostly affects older people, but now is becoming more and more common in younger people, many of us physicians, but also patients, don't really know what a young patient with colorectal cancer is going through. And this is really the goal of our education day today, is to educate patients, caregivers, families, but also caregivers themselves about what are some of these important factors that people are dealing with when they're going through conditions that not everybody knows about. So it's really about educating and about raising awareness. And we have a great agenda of experts talking about different issues. Since this is the 10th iteration of the Education Day, we're trying not to rehash things that we have spoken about before, because many of our patients come back, and I welcome everybody who's online as well currently. So we try to come up with new topics every year, and we have the foremost experts talking about these topics. So it is really with great pride that I want to introduce the first session. And the first session is really emblematic of what's important and why centers as ours exist. The care of people with hereditary conditions or with young-onset colorectal cancer, it doesn't require one single physician or one single specialty, but it's really a collaboration between many different doctors from different specialties. So our first session is going to be about multidisciplinary care in young-onset and hereditary colorectal conditions. And really the best person to start off that session is my partner, Dr. Carole Burke. She's a gastroenterologist, and it's really not an exaggeration for me to say probably the foremost expert in the world on hereditary colorectal cancer conditions. And she'll be talking about the importance of endoscopic screening and surveillance and how adherence is really important. Thank you, Carole.
Thanks for that nice introduction, David, and welcome everybody both in the room and online. Javier hooked me up with sound. Simple. As Dr. Liska said, endoscopic screening and surveillance is really important for a variety of reasons, and I'll tell you exactly why I think that adhering to surveillance and screening guidelines is important. So I asked some of the trainees, what's your lifetime risk of getting colorectal cancer? Average risk individual, and sometimes they don't know. It's about 5% for both men and women, and that's cumulative lifetime colon cancer risk. If you have a personal history of polyps or you've had colorectal cancer, your risk of getting colon cancer in the future is increased about 2 to 3-fold. And if you have chronic inflammation, most cancers are related to chronic inflammation, so things like Crohn's disease and ulcerative colitis, primary sclerosing cholangitis, which is a liver condition, increase the risk almost 40%. And then the inherited colon cancer syndromes that we see most commonly at the Weiss Center, and they're the probably most common hereditary cause of colon cancer, Lynch syndrome and familial adenomatous polyposis, the risk can be anywhere from 20 to nearly 100% lifetime risk. So in the registry, our approach to patients as well as caregivers, the major principles we guide our treatment and recommendations by is to prevent death from cancer. Now, we can't avoid cancer occurring in 100% of individuals, but we don't want anyone to die from it. We also want to maintain organs. So in these hereditary conditions, not only the colon, but other organs are at risk of cancer. And so if we can do things to prevent another organ being removed, because these diseases are not surgically curable, that's our aim. And certainly, along with those two, we want to enhance quality of life. So the life that all of us have to live, we want every day to be worthwhile. And so our registry works under the premise of we want to educate not just patients, and sometimes we want our patients to be smarter than their providers. If they don't have access to the Weiss Center all the time, we're always a resource, but we want our patients to know when a provider offers some management suggestion that doesn't seem right, that they can contact us. Increase the awareness of these disorders and the risk to family members. We provide support like the education day, and then the registry function is to ensure that we're contacting our patients and their families to be sure that they know that they're due for their procedures, schedule them. And these are not so rare disorders, at least in the Cleveland Clinic, but we contribute in many ways in research, and you'll hear a little bit about why it's important to participate in a registry and allow us to perform research in these syndromes so we can help next generations. So endoscopic screening, the use of scopes to look inside the intestinal tract, we know decreases both colorectal cancer incidence and death. And we can detect cancer early when it's curable. So for people to say, I don't have any symptoms of change in bowel habits, rectal bleeding, unanticipated weight loss, I don't need anything done, that's not true. We're all at risk of colorectal cancer. And so if you have your screening tests and something is found in the early asymptomatic phase, you're curable. We can remove polyps to prevent cancer. So not only early detection, but the prevention of cancer. And then, as I said before, preserve organs. So if you take a look at the top left of the screen, you can see a patient with multiple little bumps, and that's in the rectum. Let's see if I have a cursor here. And this is one of our patients with polyposis. And if we remove those, then we prevent them from growing bigger and turning into cancer. These are views of normal colon, and I shouldn't say normal because what we don't want to see when we're doing a colonoscopy is a little brown bowel movement that's still in. We want the colon completely clear so we can find polyps and remove them. And if patients don't have screening and they don't have surveillance, then these things can lead to a cancer. And this is just what a cancer looks like inside of a colonoscopy, and that was in one of our 19-year-old patients. So people in the audience may be at average risk of colorectal cancer, and there are national and international guidelines to suggest what should be done. They can include stool tests, which are non-invasive, which is either called a FIT test, where you're looking at an immunochemical reaction on a slide, and it's one test. It's like a pregnancy test that gets sent to the lab, or you can check for stool blood. And the fecal immunochemical test actually is taking over from checking the stool, 3 different stools for blood in it. There's also the dancing box that you've probably seen. It's the multi-target stool DNA that uses a FIT test, but in addition, it looks at genetic changes in bowel movements to pick up some other types of polyps. If any of those are positive, you need to move on to have the colonoscopy to find out why those screening tests were positive. And so those are kind of 2-step tests. The scope tests include colonoscopy, which examines the 6 feet of the colon, or sigmoidoscopy, which is the shorter scope, which can be coupled with the FIT test every year. And colonoscopy is done every 10 years if normal. The other types of tests that are commonly used, insurance doesn't necessarily pay, includes a CAT scan, where they can render images on CAT scan to look like a colonoscopy view. There's capsules that can be done, again, not as good as some of the stool tests in the colonoscopy, and blood tests are on the way. Suffice it to say that colon cancer screening, because of early onset, should begin at the age of 45. If people have family members that have had advanced colorectal polyps or colorectal cancer, generally we begin earlier at the age of 40 or 10 years younger than the earliest age of the person with colon cancer in the family. And these slides will be available, but I've documented it here. It's dependent on the age of the relative when they were affected. And if you have a first-degree relative with colorectal cancer or an advanced polyp over the age of 60, you begin at the age of 40, and it's average risk options, right? So if my dad had colon cancer at the age of 92, I might have my first thing at the age of 40, but my risk is not as high as someone that has multiple relatives at a younger age, which is less than 60. For individuals that have had colon cancer, the National Comprehensive Cancer Guidelines suggest that if the preoperative colonoscopy was complete, they were able to go past the tumor and make sure there was nothing else in the colon, the next colonoscopy is in 1 year to look for polyps and cancer. And then if things are looking good, then it extends out to 3 to 5 years, depending if it's normal or there's polyps found. And the only difference between colon cancer and that surveillance and rectal cancer is that if someone has a transanal excision of cancer, then they have a short scope with consideration of endoscopic ultrasound or MRI every 3 to 6 months. So for rectal cancer, for certain types of removals of those tumors, they have a slightly different surveillance program. So we're here to talk also about hereditary colorectal cancer syndromes, and there's a myriad of them. These are colon cancer syndromes, but you can see on the left part of the slide that there's many features from brain, to uterus and ovaries and testicles that can be at risk of cancers. The polyposis conditions, multiple polyps, again, systemic diseases with many organs at risk of both benign and malignant tumors, and then some of these rare hamartomatous polyposis conditions that I'll talk a little bit about. The two most common polyposis conditions are FAP and its cousin MAP, and there's many features, as I mentioned. They can have desmoid tumors, which is the image in the middle left here. This is a large tumor within someone's abdomen. Thyroid can get cancer. We can pick it up sometimes when people go to their eye doctor and they have these black spots. They're called chirpy in both eyes. They don't affect vision, multiple. And then you can have osteomas, which are bone growths, extra teeth, a variety of things that a tip off to a parent could say, oh, my child has that. Maybe I did give FAP to them, but genetic testing is the way to go. So in these polyposis conditions, usually we look in the upper tract where polyps can be in the stomach and the small intestine. And you can see that the risk of gastric cancer is increasing as people age. They live past when their colon is removed, up to 5%. Duodenal polyps are quite common, and duodenal cancer is based on the stage of duodenal polyposis. So doctors actually, in their report, will put numbers, size, and when they get the pathology back, they assign a stage, and that informs us how frequently upper endoscopic surveillance needs to be. But suffice it to say, for these polyposis syndromes, the money early in life starts with looking at the colon and then making a decision when the colon needs to come out. And so there is surveillance available for that. Thyroid ultrasound is also included. And then when people have their colon removed, they're not done. They need to continue to see their provider because the at-risk rectum or the pouch still needs to be surveyed. The last few minutes, it's these unusual but very curious and interesting hamartomatous polyposis syndromes. So FAP and MAP could be 1 in 10,000 or 2 to 3% of people carry one of the mutant YH, the MAP genes, but these occur in 1 to 180 to 300,000. And they're interesting because they have some external manifestations, including pigments on the lips and Peutz-Jeghers syndrome, a funny type of polyp typically not seen in the other syndromes, and can affect children as early as age 8, as well as adults. And they are associated with cancer risk. Juvenile polyposis syndrome, the pictures that I'm showing you are someone's stomach with JPS. And this is when many polyps are resected, and that's when the polyps are out of the patient, and then they have these funny juvenile polyps in the colon. Again, can be associated with colon and gastric cancer, stomach cancer, as well as some bleeding disorders. And then Cowden syndrome, we have international experts in Cowden syndrome, P10 hamartoma tumor syndrome. A large head is one of the most common manifestations, but a variety of different cancers that I've mentioned there. So there is guidance also for the hamartomatous polyposis syndromes, which includes not only the intestine, but outside of the intestine. So in conclusion, I want to say that inherited colon cancer syndromes are associated with a high risk of cancer, and there are management strategies that we can offer to our patients and their families to decrease the cancer risk. And we can't prevent all cancers. I feel like I've let my patients down when they come for their exam and say, well, I was here last year, and how could I have cancer? Because these are cancer syndromes and there's a very high risk. So we can diminish the risk, but sometimes we can't prevent it 100%. But we certainly don't want anyone to die from cancer, and we want to improve the quality of life. So thank you for your time and attention.
Thank you so much, Dr. Burke. This was great. A few housekeeping items before I introduce the next speaker. So for all those people online, we will have a panel for questions at the end. So feel free to even now start putting in your questions into the chat if you have any questions. Anyone here in the audience, we'll call on people, when we have the panel for any questions that come up. So just remember the questions if they come up now, and we'll save them for the panel at the end. So, but now I want to introduce our next speaker. And like I said, taking care of hereditary and young onset patients is a multidisciplinary endeavor. And it's obvious that we have gastroenterologists, but we're also very fortunate to have Dr. Karen Hurley, who's a psychologist who specializes in helping patients with hereditary or young onset colorectal cancer conditions. So Dr. Hurley will be talking to us about overcoming challenges in adherence.
It really is a privilege to be here and to participate as a member of the Weiss Center team. And so I wanted to say hello. I'm meeting some patients for the first time who I have met virtually in psychotherapy sessions, and also greetings to people who are dialing in virtually. So to get us started off, so in talking about adherence, what we mean by adherence is following a doctor's recommendations to do what they ask us to do and at the recommended frequency that they ask us to do it. Obviously, adherence applies to the screening tests that Dr. Burke was just talking about, the colonoscopies, the FIT test, but behavioral issues occur throughout the cancer spectrum, and they apply both to hereditary cancer syndromes as well as young onset colorectal cancer. So adherence might be things like following the cleansing program that you have to do before your colonoscopy. It might be, if you're an FAP patient, taking your Sulindac medication. It might be following recommendations for diet and exercise, and it might be for taking care of a stoma, right? So these principles apply across a wide variety of requirements of things that you might be asked to do by your doctors. So I wanted to start with talking a little bit about the history of the partnership between psychology and medicine. It's a relatively recent phenomenon, started somewhere between the 60s and 80s with the recognition that in order for advances in medicine to actually benefit people, people have to do the things that they're being asked to do. So I put up a quote. This was from a well-known medical journal in Lancet, where they were trying to establish that checking for blood in the stool is an effective way to screen for colon cancer, and that it actually reduces morbidity and mortality. But you can see here that they were talking about the fact that only 25 or 29% of patients who were given these blood tests, blood kits to use at home, would actually do them. And so this suggests that compliance was the factor limiting the screening technique. So this is an early example of the acknowledgement of how important adherence is. But notice the change in language. Back in the 80s, they were still talking about a compliant patient, more like an obedient patient. But you can hear there's a little bit of a scolding tone to it, right? A little bit of a top-down, naughty child kind of connotation. And so there was this shift into talking about adherence, which paralleled a shift in general in the relationships between health professionals and their patients to develop something that was more of a shared decision-making model, more of a collaboration model in order to improve the ability to follow through on recommendations. So one of the very early psychology theories that was used to try to understand why do people follow or not follow their doctor's recommendations This is called the health belief model, and it basically proposes there are 4 issues you have to look at in order to see who's doing what they're supposed to or being recommended to or not. You have to perceive that if you think that you're going to get sick if you don't do this thing you recommended, that the problem will be serious if you don't do it, that it will help you reduce the threat to your health, and how difficult is it. So it's pretty straightforward, right? And then some of the things that psychology studies found that get in the way. Number 1, forgetting, right? You forget when your appointment is. You forget, wait, did she tell me to come back in 1 year or 2 years? So, that's one of the reasons that we're fortunate at the Weiss Center to have coordinators to help people keep track of complex recommendations and staying on track. Things like cost and logistics. Surprisingly, phobias are a fairly common barrier to adherence. People who are afraid of needles, afraid of small spaces. This is a good reason to see a psychologist, because if you're living with a condition that is lifelong, then taking care of these will improve your quality of life in terms of following the recommendations. And then there, of course, is anxiety, which we will talk more about. Now, however, these 4 principles of why do people do what follow or not follow health behaviors only accounted for about 20% of whether people actually do what they're supposed to do. So it leaves a big X factor, and it came, through years of study. We identified that this rational model, that if you balance out what are the risks and what are the benefits, that you should arrive at the logical conclusion that you would do this behavior. Well, if people were that easy to understand, I would not have a job. Okay, so now we're going to move into sort of some second generation understanding of behavior and how that's being applied in cancer care and cancer prevention. And any of you who have seen me in therapy may have heard me talk about this at some point. So there's a theory called self-determination theory, which posits that we have 3 basic needs, and this is for everybody without exception. We need to feel autonomy, that we're free to make choices. We need to feel competent. We have abilities that make us confident, give us confidence, and we need to feel connected to other people. So when these needs are being supported, when you feel like people value this in you and support you in expressing autonomy, competence, and relatedness, that you develop goals that come from you. And when you have those goals that come from you, you are more motivated to meet them. You're kind of in harmony with yourself. And that's the real engine of motivation that lets you do things that are complicated. You set a goal and go through a series of steps to carry it out. This theory has been shown to be valid in a wide variety of cultures. So it has, so it can be applied pretty broadly. Now, the thing is, so when we think about sort of what is an intrinsic goal, what's something that comes from you, it's something that's self-identified. It's because it's important to you. By contrast, an external goal, something that doesn't come from you, something that's top-down, that you have to comply to because I'm forced by others. So if you're doing something merely because somebody told you that you should, that doesn't give you that engine of support that motivates that healthy behavior. Now, interestingly, it can come from outside, but can also come from the inside, because you can have an internalized voice in your head telling you and scolding you, I should be doing this or that. It's still a controlled voice, not an intrinsic voice. So what are some examples of a goal that would be considered intrinsic? I want to do everything possible to be around for my kids, right? I hear a lot of patients expressing that heartfelt goal. I've decided this is my best way forward. And it could even be, Dr. Burke is really smart, and if she says this will help me, I'm on board with it. That's not doing it because she said so. It's doing it because you value the connection and you value the advice that you're getting. Therefore, that becomes part of the engine of motivation. So the catch, and this is where the rubber really hits the road with cancer, is that cancer and cancer risk challenge all three of these values that we have. It can affect your autonomy by knocking you off track. It affects your competence because you can't do the things that you normally can do. And it can isolate you, taking you out of the flow of your everyday life through the demands of treatment or intensive screening. So this is why the attention to these three are so important in generating the motivation to take care of your health when you're under this degree of threat from cancer. So this is where we get into problems sometimes. When people get into this mood of cancer is not the boss of me, they'll maybe skip a screening, not because they don't understand that it's important, it's because it's a way to assert autonomy when cancer has taken so much other autonomy away. So this is where you have to do some kind of deep internal questioning to get yourself back on track. So in conclusion, what can be some steps towards generating that healthy attitude towards adherence? First, validating what's important to you, not necessarily what's important to other people. What's your personal motivation going to be? And paying attention to how you actually feel, not how you should feel. So if you are feeling bossed around by cancer, you want to pay attention to that, just like you would pay attention to, a fussy teenager who's telling you, you're not the boss of me, and is going to go do things that they know are dumb, but they want to be able to assert themselves. So we find ourselves kind of getting back into that mindset. You want to find allies who support your goals, who understand why you as a person are making this choice and help you get there, and being skillful. And taking that first step towards an effective action gets that engine of motivation going to move you through to meeting your goals. So to close, I wanted to circle back to anxiety and just give you two techniques of what I call emotional first aid to help you move through one of the potential barriers to adherence. The first one I call breath brush, and you can just do this, it's very easy. It means take a normal breath, not any kind of special deep breath, but just imagine that it can travel inside, and any part of you that is tensed up with anxiety, it just brushes right over it like a feather or like you were stroking a baby's forehead. So you're accepting the anxiety, you're not trying to get rid of it, and you're soothing it with your breath. The other thing that you can do is, we can do it right now. Look around the room and name 3 things that are blue. Dr. Burke's shirt, this gentleman's wearing a blue shirt, and the screen is blue. Now name 3 more things that are not red. I see a brown railing, black camera, and a green stripe on this paper. It's a distractor that helps you kind of reset your brain if your thoughts are spinning out of control. You can do this in the waiting room. Nobody knows what you're doing, except now Dr. Burke or Dr. Liska will, because if you're looking like this, you're doing the color naming thing. So with that, I want to say thank you very much for your attention, and thank you for the invitation to present.
Thank you so much, Dr. Hurley. These were some great tips and advice for our patients and for us as well. So for the next speaker, it's going to be a virtual talk that Dr. Kurowski recorded. And Dr. Kurowski is one of our pediatric gastroenterologists. And as we heard from Dr. Burke, some of the hereditary conditions definitely start affecting our patients when they're children. And children are not just little adults, right? Children have a separate set of considerations that we need to think about when taking care of them. So we are very lucky to have a pediatric gastroenterologist that is part of our Weiss Center. And with no further ado, we'll hear from Dr. Kurowski in the recorded talk.
Welcome, everyone. My name is Jacob Kurowski, and I'm a pediatric gastroenterologist with a focus in hereditary polyposis syndromes here at Cleveland Clinic. I apologize I could not be present today, and thank you for your attention and patience for this presentation. Today, I'm going to discuss the importance of personalized care for your children with polyposis syndromes, identify the team members recommended for ongoing care for polyps, and discuss the method and timing of optimal transitional care for young adults with polyposis syndromes. There are 4 main polyposis syndromes that we see with a pediatric age onset that I will briefly review. These include familial adenomatous polyposis syndrome, or FAP, juvenile polyposis syndrome, Peutz-Jeghers syndrome, and P10 hamartoma tumor syndrome, often known as P10 or Cowden syndrome. Each polyposis syndrome has a little bit of its own flavor, and like many things in medicine, there's some variability patient to patient, family to family. In general, when there's a family history of polyposis syndrome, of which all are autosomal dominant, there's a 50% chance of a child inheriting the syndrome. If there is no family history and a polyp syndrome is found, genetic testing will occur after a colonoscopy. In general, we will recommend genetic testing to occur not at birth, but at the age when the first is due to occur. In general, we strive for optimal surveillance, not too much and not too little, meaning that we will always provide the highest standard of care for your child and recognize that some symptoms may be a normal part of childhood and not necessarily attributed to a polyposis syndrome. Lastly, there are always exceptions to these rules. Now, we are going to review the screening guidelines and a few facts for each of the polyposis syndromes. The first and most common is familial adenomatous polyposis, which affects 1 in 10,000 people. As I mentioned earlier, genetic testing typically occurs prior to the need for the first screening test or colonoscopy in this case. In FAP, the first colonoscopy is recommended at 10 years of age. Therefore, genetic testing would also occur near or at 10 years of age. If a mutation consistent with FAP is present, a colonoscopy would follow in the coming months and would then occur on an annual basis. The first upper endoscopy is recommended to start at around 20 years of age. However, this may occur earlier if there are any symptoms in which an upper endoscopy would be helpful to investigate, or if surgery is going to occur before 20 years of age. That said, the average age for a patient with FAP to have surgery is about 20 years old. And there have been several research studies evaluating medication for FAP. In general, chemoprevention with a medication such as Solandac is not routinely recommended, but is used in specific cases with exceptions. Last, a thyroid ultrasound should begin in the late teenage years. Our next polyposis syndrome is juvenile polyposis syndrome, which affects approximately 1 in 100,000 people. There are several genes that have been linked to juvenile polyposis syndrome, yet only about 50% of people have an identified mutation. This means we still have a lot to learn about this disease. For those whose family have an identified mutation, genetic testing starts at around 12 years of age or sooner if symptomatic, with the exception of those with a mutation in SMAD4. Those with SMAD4 are screened in infancy so they can be evaluated for another condition associated with this gene called hereditary hemorrhagic telangiectasia, which results in vascular malformations and needs to be followed from a young age. Endoscopies, both upper endoscopy and colonoscopy would also then start at 12 years of age if a mutation is found, and then occur annually if polyps are present, or every 2 to 3 years if there are no polyps. As I mentioned, only about 50% of patients have an identified mutation, so there is significant variability in the polyposis syndrome and harder to follow in families. Next is Peutz-Jeghers syndrome, which affects approximately 1 in 200,000 people. Genetic testing begins at 3 to 5 years of age and by 8 years at the latest. There is a little more variability in the timing of genetic testing because this syndrome causes polyps to grow in the middle of the small intestine, which can be harder to find. And so, knowing in an earlier age helps when monitoring signs and symptoms that may need evaluated. If there are no signs or symptoms, the first endoscopies occur at 8 years of age. This includes an upper endoscopy, a colonoscopy, and an evaluation of the small intestine with either a capsule endoscopy, an MRI, or a CT scan. The decision to use one of these is dependent on the patient and which center you're located and their capability for performing these studies. Some patients will require both a capsule endoscopy and an imaging study to help monitor. We typically place the capsule endoscopy during the time we are performing an upper endoscopy, if these are large and difficult for a child to swallow. The upper endoscopy and colonoscopy frequency is dependent on the findings at 8 years of age. If polyps are found, then the endoscopies are repeated every 3 years. If no polyps are found at 8 years, the next endoscopy is then at 18 years of age and begins every 3 years moving forward unless symptoms develop sooner. However, monitoring of the small intestine with the capsule endoscopy or imaging study continues every 2 to 3 years based on the findings starting at 8 years of age. Preferentially, we typically monitor with either capsule or MRI to reduce the amount of radiation exposure at a young age. Last, males with Peutz-Jeghers syndrome will begin to have an annual testicular exam starting at 10 years of age to monitor for possible growths of the testes, and females should have a comprehensive physical exam to monitor for signs of early puberty starting at 8 years of age. For females, this does not routinely include a pelvic exam unless indicated by an endocrinologist or gynecologist. The last syndrome is P10 hamartoma tumor syndrome, or PHTS, which affects approximately 1 in 200,000 people and is now the gene identified for syndromes previously described as Cowden syndrome, Benayan-Riley-Ruvalcaba syndrome, and Proteus-like syndrome. Genetic testing for PHTS occurs when symptoms present and may be at varying ages when recognized. The most common pediatric manifestations include autism spectrum disorders, macrocephaly, or having a head circumference greater than the 97th percentile, lipomas, or growths of fat anywhere on the body or in the abdomen, and numerous different skin lesions, including tricholomas, papillomas, or neuromas. The first colonoscopy for patients with PHTS is not recommended until 35 years of age or 10 years earlier than the youngest age of colon cancer in the family. While colon cancer occurs in up to 18% of patients, the average age of diagnosis is in the mid-40s, which gives children a very, very low risk. There is no recommendation for an upper endoscopy, though we do see a higher rate of eosinophilic GI disorders, including something called eosinophilic esophagitis, which is a type of allergy in the esophagus in patients with PHTS. A thyroid ultrasound begins at 7 years of age and occurs annually. For females, breast awareness, including self-exams, are recommended starting at 18 years of age, and annual physical exams for both males and females is also recommended starting at 18 years of age. So now I want to talk a little bit more about the nuts and bolts of how we practice at Cleveland Clinic. If you're not already familiar or haven't had the opportunity to meet one of these wonderful coordinators, Lisa LaGuardia and Margaret O'Malley are clearly the special sauce that makes everything run. They are involved with the preclinical and the post-clinical care and coordinating everything in between. Each patient is enrolled in our registry, and while the patients are seen in the adult clinic, the children are seen in the pediatric clinics. It is very important that children and young adults are part of the decision-making process. Obviously, this can be age appropriate, but explaining to a child at their level what the syndrome is, and very importantly, what a colonoscopy is and what to expect for their procedure goes a long way in reducing anxiety and medical trauma associated with invasive testing. We then have twice monthly meetings with all members of our hereditary polyposis team to discuss recent testing results, comparing results from children to parents, providing updates if patients are needing surgery, and address any patient-specific challenges, to discuss any unusual findings and plan for any other procedures that might be needed. Our ideal multidisciplinary clinic includes pediatric and adult gastroenterologists, caring surgeons, genetic counselors, social work, psychology, and of course, the coordinators. I feel very fortunate to work with such an amazing team. One important area that I can't emphasize enough is the importance of mental health in hereditary polyposis syndromes. Each syndrome has risks at different stages of development, and disease perception evolves with that development. And so, having a mental health expert, either a psychologist or a therapist, involved in the program can improve quality of life in our patients. They can also address skills of transition readiness along with mental health challenges. When we talk about transitional care, we are referring to the planned movement from pediatric-centered care to adult-centered care. However, healthcare responsibility transitions from the guardian or parent to the patient, while a patient transfers from pediatric to the adult provider. This process requires preparation by the patient, the guardian, and both the pediatric and adult physicians. This transition of responsibility before the actual transfer of care occurs based on the development and maturity of a patient, along with the family's readiness and support. In hereditary polyposis syndromes, the family history plays a much larger role than in other disease processes. In addition, surgery is an important factor when considering the timing of transfer from the pediatric to adult physicians. We do expect that young adults can identify their polyposis syndrome, the risks, and other manifestations of their syndrome before they transfer to adult care. In summary, personalized care is mandatory for hereditary polyposis syndromes. Teamwork makes the dream work here at Cleveland Clinic, and preparation for transfer of care by the patient, the parent or guardian, family, and all team members is required. Thank you for listening, and to all my amazing patients and team members, have a wonderful day.
All right. Thank you very much, Dr. Kurowski, in absentia. So the next speaker is going to be Dr. Griebeler. It's also a pre-recorded talk, but he will join us for the panel of questions. So please, again, we've been getting some questions online already. Please keep them coming. The reason why we have Dr. Griebeler here, so Dr. Griebeler is an endocrinologist who specializes in weight management and obesity. And when talking about young-onset colorectal cancer, the question that almost always comes up is, why is this happening now? Why are we seeing more and more young people with colorectal cancer? And one of the answers, we don't have all the answers, but one of the answers that we have noticed that young-onset colorectal cancer is happening mostly in Western countries, and it's happening globally, but mostly in Westernized countries. And we definitely believe that it's something to do with the environment and, with the type of foods we eat. And it's not surprising that it's parallel to the obesity epidemic that we're seeing here in the United States. And it's definitely not the only factor. We have plenty of young people with colorectal cancer who are fit, active, and healthy. However, we do know that being overweight or obese, sedentary lifestyle are associated with a higher risk for colorectal cancer. So that's one of the reasons why it's important for everyone really to maintain a healthy weight. And the other thing that we as surgeons particularly focus on as well is that when we do surgery, which many of our patients need, the risks for complications from surgery are higher in people who are overweight or obese. So we encourage our patients, especially when you know that you're going to need surgery, not immediately, but you have some time to prepare for surgery, we encourage them to do whatever they can to get to a healthy weight. And often that is easier said than done, and our patients need help to do that. And we are very fortunate at the clinic to have specialists that we can refer patients to help achieve that goal. So I'll bring up the talk of Dr. Griebeler next. Like I said, he's an endocrinologist, and I'm very excited to hear his talk about optimization before surgery, healthy weight loss.
Hello, I'm Dr. Griebeler. I'm the director of the Diabetes Center and the Obesity Center under Endocrinology. Today we're going to talk about a healthy weight loss that is very different than dieting. So we'll discuss why it's so important to manage weight for your overall health, what happens to your body when you're losing weight, and to understand weight loss is much more than diet and exercise. We need to understand that obesity is the main driver of many medical problems. Here on this graph, I show the increased prevalence of diabetes and obesity, and they are really correlated. But we do know that obesity increases the risk of many other medical problems, including cancer. So it's very important to treat as early as possible. So if we do treat obesity, we will also treat the other comorbidities. Weight loss will help with management of many comorbidities, including osteoarthritis, cancer, fatty liver disease, if not many more other diseases. We also need to understand that this is what is going to happen with all patients when we are helping them to lose weight. There is usually an initial phase of weight loss where there is more rapid weight loss. We call the acute phases. In the past was 3 to 6 months, but now with new medications available and other interventions, we stretch that out to close to 12 months. But after this intervention, usually there is a weight plateau and it's harder to lose weight. We need to understand that because it will happen to all patients, and a lot of patients feel frustrated because of that. They feel that is not working the treatment anymore. Actually, this is a very normal response of your body. We just need to work around that. So I usually tell my patients that the weight loss is the easiest part of any obesity treatment or any weight loss intervention. The challenge is to maintain this weight that you lost. Obesity and weight management is a chronic, ongoing medical issue. We're not going to fix with a diet intervention for a few months and think that's gone, because this requires chronic management. We always have to be working on those connections of your brain with your gut. This is very, very important. So there is a concept that we are using more and more, and I try to explain this to all my patients. The weight set point, your body is fighting to put you back on the weight that you were initially. Is a protection of your body against what we call starvation. We don't have issues with access to food usually, like we had many years ago, not long time ago, but we had. Now we have easy access to food, so your body is not ready for that. And your body always is thinking about preserving as much energy as possible. So when you are doing a diet or any intervention, your body is going to try to release some hormones to protect you from further weight loss. And these are just some examples where we can see patients starting a diet and they go back to the usual weight that they were before. Happens to pretty much all patients. So there is a lot of work to do on that sense. And And we can help that. This is actually, we can change the set point. It's not easy, but there are many ways to do that. So I usually tell our patients, our goal is not weight loss, but actually to change the set point so your bodies adjust to that new set point and the weight will come off or be stable after you lose the weight. Okay, this is another example here. So when I see a patient, I try to explain in medical terms the physiology of obesity. So I try to explain to what happens to your metabolism as you are losing weight, because this is very important. As you lose weight, this gap of hunger and energy expenditure, meaning the energy, the calories that you burn, it widens. Okay, so you are hungry and you are spending less energy as you lose weight. So it gets harder and harder to lose weight. So our goal is actually to narrow the gap. So hunger and energy expenditure are on the same level. Why this happens? Well, we do release some hormones that will make it difficult for you to lose weight. For example, more ghrelin make you hunger. Less GLP will make you full less often. So you want to eat again. So this is what we are against to when we are trying to lose weight. And we have to work on those things as well. So that's the reason that I say it's much more than diet and exercise. There are a lot of energy balance changes in your life. We are in an environment right now that is easy to gain weight because there are a lot of things going on. We have easy access to food. There are a lot of stressors, so we need to be aware of that. There is a food industry, environment, social media, work-life balance, mental health, super important. We need to take care of that as well because we'll release, if you're not in a good position, we'll release some hormones that will make it difficult for you to lose weight. Obviously, we can modify a few things like diet, exercise, stress, medications that cause weight gain, sleep. Those are very, very important. And there are things that are harder to change, but we can deal with that. We can help patients. Aging, everybody's aging. I'm aging, you are aging, but there are ways that we can help to age in a healthy way, preserving muscle mass, preserving energy. So this is very important, and we need to be aware of. So usually, this is what we see in patients trying to lose weight. This is a clear example. Patient start a new job, there is some weight gain, try a diet, weight loss, then regain after that, start a medication, lost weight, stop the medication for weight loss, regain the weight. So all those are, we are not dealing in a chronic way. So that's the reason that it's difficult to sustain the weight loss. So what do we have available right now? There are many, many more tools. All kinds of intervention is very important to work with your doctor in a multidisciplinary approach, where we have dietitians, exercise physiologists, psychologists. We have a great team. We work with other subspecialties and everything. The weight loss now, with the new interventions, with new medications, can approach to 20, even more than 20% over time. So that's actually very, very good. Now, there are also lifestyle changes that will be very helpful. Usually will cause a little bit less weight loss. So we rely a lot on medications to help to control appetite, and there are very powerful medications as well. And there is also a role for surgical intervention as well in certain patients. So remember when I was talking a little bit about set point, there are things that will lower your set point and things that will increase your set point. So those we are always managing, okay? We need to work about dietary changes, healthy eating. We need to work on the stress management, lifestyle changes, physical activity, sleep. We use the weight loss medications, bariatric surgery to bring the set point down to help patients to achieve their goals. But at the same time, there are other things, if not in balance, that will increase the set point and will increase the weight gain over time. So talking a little bit about diet, a lot of patients come to me and ask, what is the perfect diet? Is there a perfect diet? There is no perfect diet. Actually, we don't want to use the word diet anymore because it implies restriction. Our goal is actually a healthy eating, quality food eating, and behavior changes regarding the diet. When they did it's difficult to do studies with diets, but we can see that any diet may work, and any diet you may see significant variation on the weight loss. Some patients will lose a lot of weight, some less, some even may gain weight over time. So it's not that we are here to prescribe a specific diet with caloric restriction, because it's not going to work. We need to change the set point and help patients to have a quality diet. Also, what I like to teach my patients a lot is how we burn calories, correct? That's what we call your metabolism. There is one component on the red that is the resting metabolic rate. That's, at rest, how many calories you are burning. So that's the components of that will be fat and lean muscle mass, very important, in addition of genes, obviously, but lean muscle mass is very important. Better muscle mass that you have, more calories you burn at rest. So this is very important when we do an intervention. Obviously, you also have, your non-exercise activity and the exercise. More exercise, usually more calories you burn, but we have to be aware that sometimes we see some compensation where patients that exercise more at a certain point will decrease other physical activities throughout the day, or even eat a little bit more. So we need to be careful. So our main goal actually is to increase the resting metabolic rate, the calories that you burn at rest, because with that, you'll be burning more and more calories. So if you build more muscle mass as you are losing weight, this will be very helpful. This is just a clear example. Patients that only did diet, they lost weight, obviously, but there was almost 30% of muscle mass loss. That's not a healthy way to lose weight. We really want to preserve our muscle as we lose weight. When they did diet and aerobic exercise, there is a little bit less of muscle mass loss. And then when they did weights and resistance training, maybe you see a little bit of a less weight loss, but you see significant protection and preservation from muscle mass. That long-term is one of our goals. This is just one example. I think we need to understand that as we lose weight, there is a weight plateau, and it's happening now close to the 1 year when we are using the new medications for weight loss. So we have to understand this is a normal response of your body. You lose weight, there is the metabolic adaptation, the hormonal changes, the changes in the metabolic rate. That's going to slow down your weight, and then it's going to plateau. And then hopefully with that, we change the set point. We are in a consolidation phase, and we keep working other things to keep this going. But the weight plateau is normal, is seen, is expected. So we explain that to our patients, so there is no frustration regarding that. In an ideal goal, what you want is to have this weight plateau and further weight loss, and usually this is with muscle mass preservation. We have, I want to just touch a little bit of medications for weight loss. We have many new medications available. And we are getting now with the new ones close to 25% of weight loss. That's a significant amount of weight loss. And the ones available in the market now can cause up to 16% of weight loss. The average, this is very, very significant. So there are a lot of research in this area. So the future is really bright for helping patients to lose weight. This is one a very important clinical trial that we had showing the average weight loss of 16.9% in 1 year with this medication for weight loss. And actually, a good percentage of patients, 35% of patients lost more than 20% of weight. That's amazing. It's very close to bariatric surgery results with the new medications that we have available for weight loss. The problem here is, remember in the beginning that I said this is a chronic management. We cannot just take care of this for 1 or 2 months and forget about. It's an ongoing treatment. If you stop, there is weight regain. This is a clinical trial that was done where patients stopped the medications, other ones continue. The ones that continued the medication had more weight loss, but the ones that stopped had weight regain. So there is work to do, and we do need to be aware of that. There are many, many, many new medications available. for weight loss, and that's going to be coming to the market in the next few years. So like I said before, the future is really bright. I want to just give an example of this medication here we call triple agonists that may be approved in few years for weight loss. And we are getting like 25% of weight loss in less than a year on these medications. And they are very safe overall. And we most likely will be using more and more of that. And actually, almost all patients will lose at least 5% of weight. You saw that 100% of patients. And actually, close to 50% of patients will lose at least 25% of the weight. This is actually significant. So it's very great news, the new interventions that we have available. So I know we talked a lot in a short period of time, but this is just to give an overview how we address weight. I think we need to understand it's much more than only the diet and only the exercise. We have to put everything together, working a multidisciplinary approach, working all those domains, and also understand that sometimes you use medications for weight loss that will help to change the set point. We also have to be aware of weight plateau, that after a certain point, there is a weight plateau. Patients stop losing weight, but that's okay. It's a normal response of your body. In any kind of intervention for weight loss, we really, really want to preserve muscle. It's very important throughout all the process. And it doesn't matter if it's prior to any surgical intervention or any overall other medical problems. The approach is very similar to our patients. I hope these 15 minutes were helpful to give at least an overview about the process of weight loss. It was a pleasure. Thank you so much.
In this session, we endoscopy, pathology, and genetics. We're going to go over the basics and also beyond the basics. It's a pleasure to introduce Dr. Cruz. He is a GI pathologist. He is also he leads the molecular program at the clinic. He is also the director of pathology informatics. We're such a go-to person whenever we have tough cases and pathology to review. His talk today will cover the basics of pathology, the difference between tubular adenoma, high-grade dysplasia, and invasive carcinoma. Dr. Cruz.
So I'll talk today a little bit about the pathology, try to explain some of the things that you all may see in reports, your family members may see in reports, and kind of what these means. Try to really kind of take those down to, out of doctor speak, maybe to something that is more useful to you all. So there's no conflicts to disclose. So really, what are we doing with pathology? So as a pathologist, what I'm doing is I'm taking the excellent specimen that endoscopists or surgeons have procured. In this case, this is a submucosal dissection where they've taken a lesion out. We'll evaluate that. We will grossly look at it. We will section it. And then what we do is we put it in actually wax, paraffin. We section it very thinly, and then we put stains on it so that we can actually see the cellular detail of that. So the stains that you'll see and I'll show will be lots of pink and blue, and we'll talk about what those means. And so just kind of the basics, what does a normal colon look like? So on microscopic view from a biopsy, this is what a normal colon looks like. We've got a lot of clear cells. Here, this is the mucin producing cells. And these that you see are blue here, these are the nuclei of the cells. So they tend to be very kind of small, very orderly. And this is really just kind of that normal picture. And so, what is it that's going wrong? What's happening here? So what is dysplasia? So just a basic definition. It's really kind of any abnormal development of cells and tissues and organs. And in the GI tract, when we're talking about dysplasia, when you look at the reports, we're really talking about low-grade dysplasia and high-grade dysplasia. Think about low-grade is not awesome, and high-grade is worse. And so when we're looking at it, this is what we're looking for, right? This is a adenoma. This is what many of you will start with or have seen is a tubular adenoma, and this by definition is a low-grade dysplasia, so it's on the low end. And what we're looking for is we're looking to see, are there preserved architectural features? So do these look like glands? What we can see when they become dysplastic is the nuclei become darker because it's got more genetic material on there. We'll talk about that just in a second. They also become very pleomorphic. That's just a fancy word for meaning it changes shape and sizes. So there's very much variability in that when something goes wrong. And this just for example, again, this is our normal. And this is what we're looking at for adenomas. And so kind of what's happening here? Like what's causing this? One of the things, I'll show this graph many times as we're kind of looking through here, is that as we're looking at our progression from these low-grade tubular adenomas, this low-grade dysplasia, to carcinomas, we're really talking about the accumulation of changes. Right? Something's happened where these cells become different than the surrounding cells, right? So they can grow faster, they can survive better. And this is where our families and patients with hereditary disorders often have something in here that gives them a predisposition for this, whether they've already got one mutation and they're waiting for that second hit, or if they don't have the ability to proofread during cell division, which creates mutations. So as we accumulate these genetic changes, we're making that transition from that low-grade tubular adenoma to high-grade dysplasias, as well as to invasive cancer. And so again, that's really what we're looking for, these changes. So that genetic changes has a correlate with what we see under the microscope. And so what does an advanced polyp mean? So this is something you'll hear us often use. What does that actually mean? So advanced polyps are really anything larger than a centimeter, a tubular villus or villus architecture. So this is a fancy word for meaning lots of folds and lots of villi or finger-like projections. So as things start to proliferate faster, they begin to be crowded and take up additional space. And then what also is considered is high-grade dysplasia. So again, what's happening here is we've taken that first polyp, that tubular adenoma. We now have moved to that more advanced stage, that tubular villus adenoma, and then we'll show high-grade dysplasia. This entire time we're accumulating genetic abnormalities within those neoplastic cells. And so then what is high-grade dysplasia? High-grade dysplasia is when the cells are really starting to go bad. So they're not at the point of invasive cancer, but they've really started to lose a lot of their independent control growth factors. And what that shows up histologically when I look under the microscope, everything gets really crowded. One of the classic features is instead of that nice kind of glandular structure, you get glands and glands and glands. So we call this cribriform, but you get this growth pattern, and sometimes it can be solid sheets of these. Additionally, you'll lose nuclear polarity, and what that just means is that instead of sitting at the bottom, so this is an example of a near normal one, all the nuclei, all the blue dots are down at the base, and it's got mucin. As this becomes low-grade dysplasia and then high-grade dysplasia, they just pile on top of each other and don't respect each other's space. And then within that transition from adenoma to tubular villus adenoma, unfortunately, most of these ultimately arrive at an invasive adenocarcinoma. And that's where we've gone through the upper layer of our epithelium and we've gone down where we have the opportunity for lymph node metastasis as well as metastatic disease. And this, again, is just another picture of that where it's blown through our upper layers and into our lower levels. So here's really what's happening. When it becomes an invasive cancer, while it's restricted to this upper compartment in the adenoma stages, in the development stages, when it becomes an invasive cancer, it's exceeded down here into the submucosa. That means it's kind of broken through this wall. So there is a thin muscle membrane there, the muscularis mucosa, but just think of it as a small wall. Once it breaks through that, it has access to this space that we call the submucosa. And that's where you have vasculature. So you have arteries, you have veins, and you have lymphatics. And so this is the part where it becomes the ability to spread locally to lymph nodes as well as widely to a liver or lung. So one of the things we were asked on a previous thing is sometimes why do we not give the definitive diagnosis? So, as we work as partners together, we want to be able to give you that definitive, this lesion means this. But sometimes we have to be hedgy. So I kind of want to explain some of this because I know that this sometimes causes some of our patients concern or agita, and especially when it comes that more of our patients are seeing our pathology reports, kind of earlier now. And this is what I mean by hedgy, is that sometimes we don't have the ability to call it straight out an adenocarcinoma. So we'll use words like at least high-grade dysplasia, or at least high-grade dysplasia suspicious for carcinoma. Well, why is that? Why the heck can I just make that diagnosis? One of the things that happens is sometimes within these lesions, they become very polypoid, they can become difficult to get a scope around, or they can become very ulcerated and fibrotic. That just means as our fantastically talented endoscopists and surgeons are trying to get pieces of that, sometimes it's just not quite deep enough. So we can't tell that it actually goes into the submucosa. And here's some examples of cases where our endoscopists have done our best. These are the initial. We don't have any submucosa, so I can't call these invasive cancers. But with communicating with our endoscopists and our surgeons, we know these are mass-like lesions. We actually went back on these. Unfortunately, it did require additional procedures in all these 3 patients. But we went back, were able to prove that it was adenocarcinoma so that we could then give the patients the treatment they need. And so just kind of that, bringing it back around, as we've talked about what I'm looking at from a pathology standpoint, I'm looking at that natural progression of disease. I'm looking at it from that tubular adenoma stage, which is really what we hope we find on screening. We want to find that neoplasia, we want to remove it, and so it kind of resets the clock. But then we also watch and see if it has more advanced disease, and then, if, and hopefully it doesn't, develop an adenocarcinoma, we can start the treatment regimens then. That's it, and I'll be happy to take questions at the end.
Thank you very much. It's so nice to see this evolution from an adenoma to advanced adenoma to cancer on a slide. Now that we know what each pathology mean, we want to address how we treat them. Is surgery always the answer, or do we have any advanced endoscopic techniques that may help us remove some of these large polyps? So this takes us to our second talk. I would like to invite Dr. Sommovilla to come on the stage. He will be reviewing some of the advanced endoscopic resection techniques, which one and when. Dr. Sommovilla is a colorectal surgeon at the Sanford Weiss Center, and he has expertise in endoluminal surgery.
Thank you, Dr. Macaron, and thanks everyone for coming. And thanks, Dr. Cruz, for giving so much information that will allow me to not have to explain all of the stuff that you just talked about, because what he was just talking about is very pertinent to what I will be talking about here. So like Dr. Macaron mentioned, I'm one of the colorectal surgeons here, and one of the types of procedures that I do are advanced colonoscopies to remove large lesions from the inside of the colon. And I'm going to talk about some of these techniques and why we choose to use some of them in certain situations, and why in other situations surgery to remove part of the colon might be a better approach than some of these procedures. I should also note that we have, Amit Bhatt, who's one of the gastroenterologists in our group, does a lot of these procedures in the upper GI tract, so in the stomach and in the first part of the small intestine. So what I'll be talking about today is mainly in the colon, but a lot of these things also apply with a similar rationale to other parts of the GI system. So, like Dr. Cruz mentioned, these are colonoscopy photographs that show the progression from normal colon tissue on the left side. When we do colonoscopy, we're looking at the inner layer of the colon. So that's what we also will sometimes call the mucosa. That's the part that's visible on the inside. And that's where polyps start to grow before they start to grow in more deeply and become cancer. And so on the left, you see normal colon. This is just a light filter that we sometimes use that makes it look a little blue. And then a polyp or an adenoma. Here in the middle, this was what we would call an early adenoma. Likely you would have low-grade dysplasia. As it gets bigger and develops more changes, it may look like this, which is what we could call it an advanced adenoma, a little bit bigger. And then you could see this rough-looking thing on the right here is something that looks like an invasive cancer. And so usually when we're talking about doing advanced endoscopic procedures for these lesions, we're talking about things that are maybe advanced adenomas or very, very early cancers. So this progression usually from normal to adenoma to cancer takes a very long time, years. And this process is the foundation of why we use colonoscopy to remove polyps before they can become cancer to reduce people's cancer risk. There's some hereditary conditions where this process is accelerated, and I like to think of FAP as a condition where if you think of this as a race, people with FAP have a head start in that they form polyps very quickly and early, whereas something like Lynch syndrome, maybe that process is accelerated and it moves faster. It's a lot easier and lower risk to patients to remove these polyps and other lesions when they're smaller, but we do have some techniques that we could do to remove them when they get bigger. And so just to kind of take a step back before I start talking about the more advanced stuff, I'll just talk a little bit about how colonoscopy works and what things we might do during a colonoscopy when we encounter a polyp. So this is just a cartoon that shows the scope going in through the bottom and around the colon here, and what we kind of see on the inside. So here is a relatively small polyp, and we have different instruments that we could use to do straightforward polyp removal procedures. The most common of these are called snares or forceps. So you could see these instruments can go through the channel of the scope and we can open and close them. So a snare works kind of like a lasso where it goes around the polyp, and when we close it, it kind of snips the polyp off of the wall of the colon, and we can suction it through the scope and then send it to Dr. Cruz to chop up, put in wax, and look under a microscope. For really, really small polyps, we could use these things called forceps, which basically you pinch them onto the polyp and then pull it off of the wall of the colon. So again, these are things that we use for polyps that are usually, under a centimeter in size. Sometimes we could use snares for bigger polyps, but not for something like this typically. So this, you could see this rough area that essentially takes up the whole screen is what we would call a laterally spreading lesion, or a polyp that is quite large, much too large to get a snare around entirely. So when you encounter larger lesions like this, the question is, what do you do next? It used to be, before we developed some more advanced techniques, that these patients would get referred to surgeons to just remove that segment of the colon. And that still happens quite a lot. We get a lot of referrals for patients for surgery with large polyps like this. You might think there's a good reason to do that. It probably ensures that you're removing the whole polyp with negative margins, and it would remove any lymph nodes that go to that segment of the colon. The downside of that is, if this isn't invasive cancer, only cancers go to lymph nodes. Precancerous polyps will not spread to lymph nodes. So you don't have to worry about lymph nodes if it's not cancer yet. And it's much higher risk to do major surgery to remove a whole segment of the colon than it is to do a colonoscopy, even if it's an advanced colonoscopy. And there are quality of life implications to removing a part of the colon, especially if this is in the rectum, where the quality of life implications are a lot higher to do surgery. So things to think about for larger polyps is that cancer doesn't start in the whole polyp all at once. It starts in one area and then starts to consume the whole thing. And so precancerous polyp typically are cured by removing the entire polyp during colonoscopy. Polyps that have a minimal chance of having invasive cancer, they're often cured by complete removal with colonoscopy. And other cancerous polyps, if they're very, very, very early, can be cured by removing with a colonoscope too. whereas other polyps that have cancer in them may require a bigger surgery to remove part of the colon. So when we're approaching these lesions, our goal is to cure as many of them as we can with doing the least invasive approach that we can, and try to not remove segments of the colon if we don't need to. And that requires some techniques that go beyond the ones that I showed. So there are challenges in this. The wall of the colon is very thin. It's only a couple of millimeters thick. So you can imagine trying to scrape something like this off the inside of the colon can be pretty risky when the wall is so thin. When you're removing a big lesion like this, the risk of bleeding is higher, and then the risk of causing injury or perforation to the colon is higher. And you want to make sure you're removing the whole thing, because if you only remove part of it, then when it grows back, there's going to be a big scar there too, and the colon wall is going to be even thinner, and it's going to be harder to remove the next time around. So Dr. Cruz talked about a little bit of this, so I'm not going to belabor it, but that part on the inside that you're looking at is the mucosa. That's where the polyps start. Then the layer just under that is submucosa. So basically when a lesion starts to grow into the submucosa, that's when you call it cancer and not just a precancerous polyp. And then below the submucosa is another layer of muscle that's really the strength of the colon wall. And if a cancer is invading that layer, then there's a much higher risk that might have spread to lymph nodes by that point. So there's some terms that we're going to use, a procedure called endoscopic mucosal resection, a procedure called endoscopic submucosal dissection, and major surgery. These are the main three things that I'll talk about in the time that I have left, and I'll get a little bit into them here. So mucosal resection is when you inject the wall of the colon to thicken it and to lift the lesion away from the deeper layers. And usually after lifting a lesion with EMR, you'll use similar snares to what I showed earlier. For smaller lesions, sometimes you could use a big snare to completely remove them in one piece. But for larger lesions with EMR, you'll have to do multiple passes with the snare and take the lesion off in multiple pieces. With another technique called ESD, or endoscopic submucosal dissection, you do the same lift that you did during EMR. But then you use a little knife to cut around the lesion, and use that same knife to dissect the submucosa away from the muscle, and you could remove bigger lesions in one piece with this technique. So this is just showing a little injection needle that we would put through the scope to inject that wall, and you can see here that's thickening and giving you a little bit more room for error in removing these lesions. This is just showing that EMR. So basically the left side is the injection needle. A lot of the injection products that we use have a blue color to them. So when you use them, that's why you see the blue here. And then, I thought there was another slide in here. So then typically with EMR, you'll use a snare to take a big lesion off like this in multiple pieces. And this is just showing ESD with a similar lift. You're using this little sharp knife to actually cut a circle around the lesion and then dissect in that layer under it. And I just have a brief video here that shows ESD in live action. So this is a colonoscopy. That's a large polyp. And first you'll see here the injection needle with the lifting agent going in, and this is lifting that polyp away from the deeper layers of the wall of the colon. And usually you have to do this all the way around it, because you don't only want to remove just part of it. So this is just kind of the end of the lift. And then the new instrument, this is kind of the knife that we use. Usually what we'll do is we'll start by making a cut around it, the whole circumference of the lesion. And then after making the cut all the way around it, we'll start to cut under it to fully remove it from the deeper layers of the wall of the colon. And so what this allows is, Dr. Cruz talked about some of the pitfalls and downsides of the specimens they get. When they get a specimen that's got 20 different little pieces in it, it can become impossible for them to tell us detailed information about the specimen. So if they find cancer in it, they won't be able to give us information about margins or about some of the other things that we want to know about. They usually can tell us if there's cancer or not, or if there's high-grade dysplasia or not, but not a lot more detail than that. So this is the benefit to doing a procedure like this, is that you can get this whole polyp out, pin it to a piece of cork board, and send it to the pathologist in in one big piece. And so this is just getting the rest of it off. And so you'll be left with a defect like this that we can often put clips over. They have other fancy devices we can use to kind of close that up. Or in some situations, it's safe to just kind of leave it open and it'll just kind of heal over on its own. So that's a video of the ESD procedure. So, like I mentioned, if this is just a pre-malignant lesion, then often EMR removing a pre-malignant lesion is sufficient to cure it, because as long as you're still removing the whole thing, then you should be safe. Now, there's some benefit to doing ESD because you probably have a better idea of the fact that you're removing the whole thing and the risk of it growing back is lower. But the real trick is trying to figure out ahead of time if you think there's going to be invasive cancer. Because like I mentioned, some early cancers can be cured by ESD. This picture just shows a classification system we have for how deeply cancer can invade into the submucosa. And so if we have a very superficial cancer, a colectomy or a bigger surgery might be avoidable if you just do ESD. If it invades more deeply, then typically we have to do a bigger surgery. And the only way we can get that information is if we send them the specimen in one piece. This slide basically is just what I just said. And so we do have some tricks by looking at polyps that we can get an idea of, do we think this has cancer in it or not? Because a lot of this information you're not going to know until after you've taken it out. And ideally you would have the information ahead of time before you decide which type of procedure you're going to do. So I'm not going to get into a great deal about this, but we have classification systems just from looking at polyps about some of their features that make us worry, oh, this might be cancer, that might make us want to do ESD over EMR. So this just shows the shape of different polyps, how raised up they are, or some polyps are actually a little bit depressed below the surface. These are the ones that we really worry about having cancer in them. Similarly, we can do light filters when we're doing colonoscopy that show us the patterns of the surface features of some of these lesions, and this just shows the more benign, non-concerning lesions on the left, a normal adenoma in the middle that has this kind of a splotted pattern to it, and then you could see this cancer on the right has a very disorganized light pattern to it. And so those are things that if we see them when we're doing these procedures might change the approach that we take and make us choose one of these procedures over the other. Or if it's clear that this is just a deeply invasive cancer, not try to do anything fancy with the colonoscope and just say, hey, you probably need to have a bigger surgery for this situation. Now, this is a session for young people and hereditary cancer patients. I think we should also note that this decision-making is different based off of other things that are going on with the patient. So if we see a really advanced polyp in a FAP patient who has 300 other polyps that they probably need a prophylactic surgery for, then it doesn't really make sense to do a really advanced procedure just to remove one of those polyps. And it might be time to talk about doing a prophylactic surgery. Some other high-risk patients who have other risk factors for colon cancer also that might factor into our decision-making. And then this isn't as pertinent for this population here, but sometimes we'll have elderly patients with a lot of health problems where doing major colon surgery isn't a great option. In those situations, sometimes we will try doing ESD even if we think it may not be the 100% best procedure for a cancer cure. So just to summarize, EMR can be really good for big lesions with a low risk of having invasive cancer. It's a bit of an easier procedure to learn. It's a shorter procedure. It's probably easier for patients to find a provider who can do these procedures compared to ESD. ESD is great for lesions that you think you can cure with a colonoscopic approach, but you need to have them in one piece. And surgery is ideal for lesions that we think there's a risk of having spread to lymph nodes because those will be removed with surgery, and anything that's more deeply involved into the wall of a colon. With that, I thank you all and thank everyone for having me to talk here today.
Thank you, Dr. Sommovilla. It's an exciting field, and we're so pleased to have you, and we thank you for your effort in managing our patients. The next, and I think last talk of this session, we're switching gear. We're moving into genetics. Is genetic testing covered by insurance? Will a positive test affect my ability to get insurance in the future? Inviting Sarah McGee, our genetic counselor, who specialized in inherited GI cancers. Thank you for being here.
And thank you for the opportunity to talk today. I'm talking about everyone's favorite topic of insurance. So, let's see. So like Dr. Macaron said, I'm a cancer genetic counselor at the Cleveland Clinic. I specialize in hereditary colorectal cancer syndromes. So I see a lot of our Weiss patients, their families, and then also with the Young-Onset Center. So first we'll touch on, insurance coverage for genetic testing itself, as well as then laws that are in place regarding, results of genetic testing and if you have a genetic condition for other insurances. So I think one of the biggest questions I get is, will my insurance cover genetic testing? So most insurers will cover genetic testing to some degree as long as it's recommended by a genetic counselor. This is included in most healthcare plans, but really the amount of coverage depends on your particular plan and deductible. So even while, it may be covered by your plan, if you haven't met your deductible for the year, you might still be paying, more than someone else. But on average, most of our patients are paying under $100 for genetic testing. But again, really depends on your particular situation. But the labs that we work with are very helpful. So they'll communicate prices of, your estimate of insurance coverage for testing, before the test is fully run, so you have options to cancel the testing. Also, a lot of these companies that we use also offer self-pay prices for genetic testing. Most of these cap out at $250 out of pocket. So there is a more reasonable option if insurance is not providing good coverage for testing. As well as many of these laboratories that we work with also offer very friendly patient assistance options if, they're needed. As we know, financial toxicity is a huge issue with cancer and living with these hereditary cancer syndromes that, we want to try and keep this as affordable as possible and make sure that everyone gets access to the care that they need. So when you're meeting with a genetic counselor, be sure to talk to them about ins and outs of how all of this works so that we can try and get, the best coverage that we can. This goes for our regular kind of genetic testing that we do day in and day out. Sometimes further testing is recommended that, may be more expensive, and that would all be discussed in detail, before it is done. So that's kind of coverage for the testing itself. The other big questions we get are about, how the results of the testing may impact you when it comes to insurance in the future. So the first law is the Genetic Information Non-Discrimination Act, or GINA for short. I'll call it GINA because it's less of a mouthful. So this was signed into law back in 2008. And this protects individuals from being discriminated against for health insurance and employment based off of genetic information. And genetic information is more of a broad category. So this includes genetic test results, family history information, participation in genetic research, as well as use of genetic services such as meeting with a genetic counselor. The big caveat with GINA is GINA only applies to individuals who are pre-symptomatic. So for instance, if someone has Lynch syndrome, if they are someone that has not developed cancer, this law would apply. But if they have gone on to develop cancer, this law would no longer apply. But there are other laws that we'll talk about that help provide protections. And so the protection that GINA does provide is with health insurance, again, for patients who are pre-symptomatic. You can't be denied health insurance. You can't be charged more for health insurance based off of a genetic test result. As well as health insurers cannot require you to undergo a genetic test. There's also protections for employment, so your genetic information can't be used against you in employment decisions. So they can't decide to hire you or fire you based off of a test result, can't deny you promotions based off of a test result, as well as they can't request or require this type of information either. There are some other limitations on who GINA does not apply to. So GINA does not apply to individuals who have insurance through a private company with less than 15 employees. GINA is a federal law. There are some state laws that lower this number depending on what state you're in. I believe in Ohio, it's companies of at least 4 individuals that they have to provide coverage, but it's as long as if you have 15 or more employees, GINA would apply. This also does not apply to certain federal employees, members of the military, and Indian tribes. There are a number of other laws and rules in place that provide protections for these groups that I'm not going to go into, as it's very much more specific situations. And another question is, what about other types of insurance? Does GINA help anything there? So unfortunately, GINA does not apply to life insurance, long-term care insurance, or disability insurance. So there is no law at the federal level that prevents discrimination related to genetic information when it comes to these types of insurers. There are some states that have enacted laws that provide some protections when it comes to life insurance. At this time, Ohio is not one of those states, unfortunately, but there are some states out there that do provide some level of protection. So our biggest recommendation is, if you're concerned about things like discrimination regarding life insurance, is to put these policies in place prior to undergoing genetic testing. In general, these companies do not come back and ask for genetic testing information as long as you keep your policy going. But there is no law, preventing it. So then, the big question is if you're someone who has, a condition like Lynch syndrome or FAP and are symptomatic, do you still have protection? So there is protection under the Affordable Care Act. You may also know this as Obamacare. This was signed into law back in 2010. And this provides protection for individuals that have developed symptoms of their genetic disorder, as this would now be classified as a pre-existing condition. So the same thing as with GINA, health insurance companies can't deny you health insurance, can't charge you more, all of those things based off of a pre-existing condition. So while it's no longer GINA providing those protections, there are still these protections when it comes to health insurance under the Affordable Care Act. When it comes to employment in individuals that are symptomatic, it's a little less clear. So there is the Americans with Disabilities Act that was signed into law back in 1990. And the ADA does cover against employment discrimination based off of the presence of a disability, including disabilities that are caused by a genetic disorder. But there is some uncertainty that remains regarding employment protection for individuals that have a genetic disorder and are symptomatic that might not meet that the definition that the federal law uses as an individual with a disability. So it is a little bit more of a gray area when it comes to employment there. So overall, kind of the big takeaway points is, most insurance companies will cover genetic testing to some degree when it is recommended, and, speak with your genetic counselor about specifics. You'll also likely be, directed to talk with the company who's doing your testing, which is what the genetic counselor will tell you, as they're really also the people that are going to help get this kind of coverage and can sometimes get you more coverage, through their assistance options than what your insurance provides. GINA does protect against employment and health insurance discrimination in individuals that do not have symptoms, related to their potential genetic disorder or their family history of a genetic disorder. The Affordable Care Act is what takes over with health insurance protection in individuals that have developed symptoms related to their disorder. And unfortunately, there is no federal law that exists at this time related to discrimination based off of genetic information for life insurance, long-term care insurance, or disability insurance. And these are just some resources for each of the laws that I covered. And I'll be happy to take questions with the rest of the panel.
So there's been a lot of questions about research and participating in research studies. As you probably gathered, I've been at the Cleveland Clinic for since I was born 32 years ago. And one of my areas of interest is trying to prevent, polyps. So we prevent cancer and we can delay surgery and removing organs. But we have a really interesting partner, Stephanie Schmit. Dr. Stephanie Schmit is the vice chair of the Genomics Medical Institute, and she's also a genetic epidemiologist. And she's not here today to be with us, but she did record her talk, and it will be the nuts and bolts of research. What is it and why is it important? And we'll actually review some of her interesting data on early onset colorectal cancer.
Good afternoon, everyone. My name is Stephanie Schmit, and I'm a colorectal cancer researcher here at the Cleveland Clinic. My home department is the Genomic Medicine Institute within the Lerner Research Institute here at the clinic on main campus. I'm so sorry I'm not able to be with you there today in person, but I am excited to have the opportunity to share some thoughts about research, what it is, and why it's so important. So the main goal of research is to ultimately develop safe and effective methods to prevent, detect, diagnose, treat, and ultimately cure diseases across the continuum from disease development all the way through survivorship, and specifically in cancer to help us work towards cures for the collection of diseases that we call cancer. And so the discovery of biological processes involved in cancer onset, growth, and spread in the body are really what fundamentally make the discoveries and the evidence base to be able to develop more effective and targeted treatments and also prevention and early detection strategies. And it's important to note that these discoveries and breakthroughs don't happen overnight. They are often the result of collaborative research across many disciplines, from physicians, scientists, physician scientists, and so many others over decades and even generations. And the science, it builds upon the previous generation of research results. And it's also important to note that research requires partnerships and collaboration. So that includes, like I mentioned, physicians, other clinicians, researchers, patients, and so many others to translate ultimately these discoveries into advances and cures. And at the heart of it all really is the participation from patients, their family members, and healthy volunteers that really make research possible. And if we delve in a bit further, specifically to cancer research, this slide is from the American Association for Cancer Research, and it depicts the cancer research cycle. And so what's important here is that research progress is often not linear, it's cyclical. And we learn from prior discoveries and advances are ongoing. So the advances are really the result of constantly building upon earlier discoveries and earlier observations and then moving that forward. So insights from one discipline influence other disciplines, and discoveries made in one cancer can offer new insights and ideas to better address other cancers. And you have this constant feedback loop that you can see here on the slide. And ultimately, research is important because the better we understand cancer, the more progress that we can make towards reducing its toll on patients and family members. And so this just gives, a couple of statistics. But when we think about research supported by the National Institutes of Health, which is part of our federal government, which is one of the major supporters, perhaps the biggest supporter in terms of funding for cancer research, is that when we focus on the biology, specifically in line with today's topic of colorectal cancer and ways to detect the precursors or earlier in the development of colorectal cancer, this has led to the development of many new screening tests, which also has has greatly contributed to an enormous drop in death rates from 1970 to just a few years ago with the latest statistics. And all of this research has also contributed to major advances in surgical therapy, in systemic chemotherapy, immunotherapy, and so much more. In terms of the types of cancer research, there are 4 major buckets. So there's basic research, which helps us to understand the underlying biological phenomena that lead to cancer development and progression. We also have population-based research, which you see here on the top right, which was really focused in large populations of individuals, trying to really explore the underlying causes of cancer, trends in cancer, and factors that affect both the delivery and outcomes of cancer care. On the lower left here, you'll see clinical research, which is probably the types of research that may pop into your mind most readily, testing drugs or devices, diagnostic tools, or interventions in patients to improve all aspects of care. And then finally, on the lower right, really transcends multiple disciplines, is translational research, which takes those basic research findings into the clinic and clinical research findings back into the lab to help guide research into the future. And just to give you a framework of how these studies are set up, most clinical and population studies are trying to best mimic the scenario I'm about to show you. And it's much, oversimplified, but hopefully it'll start to get you thinking about how some of these studies are set up. So envision that a person is walking their dog. They're going down the street, and all of a sudden they walk under some huge, dark, gray cloud. And they get back home and they find they're sick. That's what's observed. We can't go back in time and determine if this person were to, walk the dog and they did not walk under that, dark gray cloud, would they be healthy? Would they be sick? Was it that dark cloud that caused them to get sick? This is our sort of parallel universe that we're trying to mimic in these clinical and population studies, called the counterfactual, which is kind of a interesting term basically for a parallel universe that we can't observe. So in these studies, we're trying to mimic this scenario and find ways to study sets of individual people and patients who are under this first set of conditions on the top, and people as similar as possible in as similar an environment as possible, with similar characteristics as those on the top, but now are in the bottom, who are not exposed to this black cloud or gray cloud, and see what happens. So we're trying to mimic this scenario as best as possible in our research studies. And you could envision that black cloud to be a certain dietary intervention, leading or not leading to the development of cancer or heart disease or some other sort of outcome. Or it could be a treatment or something that we're trying to isolate and test the effects of. So in terms of the types of studies involving human subjects, there are observational studies that help us to study the causes, prevention, detection, and treatment of cancer. And we're observing the natural course of what's happening based on patient choice. And so you take advantage of exposures that happen based on geographic location, occupation, clinical scenarios, and the exposure, for example, a dietary factor or a cancer drug is not assigned to that group. We're simply observing what happens when during the normal course of life, particular decisions are made. And on the other side, we have experimental studies. One example of these are clinical trials, where again, you're studying prevention, detection, and treatment, typically not the underlying causes of disease development, but in this scenario, the prevention or intervention, treatment, or drug are assigned to the comparison groups, usually at random by the investigator or the researcher. So there's an intervention component that allows for assignment of individuals to particular comparison groups. Clinical trials can span the gamut. I won't go through all the details of this slide, but they could be focused on, like I said, treatment, prevention, screening, different types of therapies, either alone or in combination for cancer care. They could focus on interventions or opportunities to improve quality of life or supportive care, and also new ways to diagnose and early detection or diagnosis of cancer. And if you have not checked it out already, I would strongly encourage you to visit clinicaltrials.gov, which is an opportunity to learn more about active, past, and near in the future clinical trials in our area and beyond that may be of interest. So there is a long process that especially in clinical trials for cancer drugs, that lead from the preclinic, which is research that is not conducted on human subjects, through phase 1, which is determining dosage. Phase 2 is trying to test, does the intervention or does the drug work? Phase 3 determines how well it works, and phase 4 is sort of ongoing surveillance, after a drug is approved. And as you can see in the top right, about 1 in 5, new drugs that enter clinical trials will ultimately receive FDA approval. And clinical trials are incredibly important, as are all the other types of research that I mentioned, but in particular clinical trials that now we've seen, the success of so many. Patients are living longer as a result of these trials. Doctors determine whether new treatments are safe and effective or work better than the standard of care or current treatments based on results from these trials. They help us find new ways to prevent and detect cancer, to improve quality of life. And when an individual takes part in a clinical trial, this adds, to our knowledge about cancer and improving cancer care for patients in the future. So they're a key component to making progress against cancer. Research happens at a variety of different places, including universities and academic medical centers, community clinics, community events, through the federal government, for example, the National Cancer Institute, and in laboratories, both wet and dry labs. Dry lab meaning more an office space, and a wet lab maybe being a traditional environment where you might picture, scientists in a setting with goggles and coats and all of that. So it happens whether it's observational research or clinical trials in so many different places. But it's important to remember that research begins with ideas. Now, some people, rightfully so, are nervous about participating in research, particularly when it's not clear what the research process entails, and maybe are not aware of what protections are in place for research participants, specifically human subjects. So you'll see here on the left-hand side, there are 4 principles that govern human subjects research: autonomy, beneficence, justice, and non-maleficence. And all human subjects are protected, for example, for National Institutes of Health funded clinical research under federal policies. And all research with human subjects, we have a process called informed consent, which many of you, may have participated in studies before and are familiar with this process. But it assumes that the potential risks and benefits of research are balanced, and that there's no coercion or forcing of an individual's decision to participate in a study. So there are multiple elements of the informed consent process, but ultimately the idea is to make sure the participant is extremely clear on what the goal of the research is, how it will be conducted, what are the foreseeable risks and discomforts, the potential benefits either to you or sort of larger societal benefits or benefits to future patients, and then also alternative procedures or course of treatment if that's relevant. And the entirety of the human subjects process is governed by an institutional review board. And so this is an administrative body that protects the rights and welfare of human subjects recruited to participate in research activities at a given institution, for example, the Cleveland Clinic. And so the IRB is charged with the responsibility of reviewing all research, whether before it starts, involving human participants. And really protecting the welfare and rights and privacy of human subjects. Here are just a few examples of ongoing registry and biorepository research here at the Cleveland Clinic that you may, or someone may already be participating in. from the Young-Onset Colorectal Cancer Registry, the Jagelman Registry for individuals and family members with inherited cancer syndromes, the Colon Cancer Family Registry, which is a National Cancer Institute funded study that builds off of the Jagelman Registry, and also the Colorectal Surgery Biorepository. And all of this work feeds into science really across the many, many disciplines. In early onset colorectal cancer, there are a variety of studies trying to understand the biology better, from characterization of tumor tissue samples, understanding how metabolites that come from what we eat, as well as from microbes in our guts. How does that influence early onset colorectal cancer? There are a variety of studies of lifestyle, diet, other environmental exposures, and so many more aspects that are ongoing in terms of trying to better understand what's leading to the rise of early onset colorectal cancer, specifically and in particular in patients who don't have a family history of disease. But there are also hosts of studies that are really focused on individuals who have a family history. And so here are just a few examples of such studies looking at aspirin and other nonsteroidal anti-inflammatory drug use and how that medication may relate to tumor markers and survival. Understanding genetic risk in individuals with and without a family history, understanding how we can use digital images to improve prediction of survival and diagnosis in the first place for colorectal cancer, and so many more. So I just want to close with this set of slides about my lab. And so, as I mentioned, I'm an epidemiologist, and we study population science research about colorectal cancer. But everyone here in this picture, it's our lab, which has a diversity of backgrounds, interests, and ideas. And all of our research starts with ideas and does not occur in a vacuum, as I told you at the start. And we work with a host of multiple disciplines and physicians to carry out this work. And we're all, people really dedicated and passionate about decreasing the burden of cancer. And we have a lot of fun too. We have our own, families, research get-togethers, and I hope that you'll have an opportunity to get to know some of the fantastic researchers here at the Cleveland Clinic, and consider participating in research when an opportunity presents itself for you or a loved one. Well, thank you so much. Again, I apologize that I'm not able to be there today in person, but I hope this taught you a little bit about research and gave you a bit of the research bug to get interested in learning more. Thank you so much.
Thank you, Dr. Schmit. I know you're not listening, but we're so lucky to have her. She's a wealth of experience. So we're going to go from wet lab more into the clinical research. And so I'm really happy to introduce Dr. Lady Katherine Mejia Perez. She was one of the gastrointestinal fellows at the Cleveland Clinic the last 3 years, and is spending 1 year in addition to her training learning the nuts and bolts of caring for patients and families with the hereditary germline disorders, early onset colorectal cancer. So we're very proud that Lady Katherine is joining us for the next year in this endowed fellowship. And she'll be talking about some of the research that we're doing in the Weiss Center beyond what Dr. Schmit does in her lab. Thank you for joining us.
There you go. All right. So in the next 15 minutes, I'm going to be talking to you about the output in research in the from the Weiss Center, for the most part for the past year. So we've been talking about young onset colorectal cancer and how we've realized that in the past few years it's rising, more so than the average onset colorectal cancer. It is defined by just having the occurrence of colon cancer in a person who's younger than 50 years. So far, and some of the members of the Weiss Center realized that we don't really have any idea of whether or not there are certain spots within the United States that are more affected by this condition. So as Dr. Schmit was saying, basically all of the research comes from an idea, and this was the question basically. Are there some areas that are more affected by young onset colorectal cancer than others? So the group decided to partake, and actually this is a study that was led by Dr. Smith, basically taking into account a lot of different databases. I'm doing a lot of fancy different models to try to put together whether or not certain people were dying more often from colorectal cancer. And this is basically what they found. So, and just to give you a little bit of a summary of what exactly they did. So they put people into brackets. So younger than 35 years, and these are people who died from colorectal cancer before 35, also from 35 to 49, and then overall just everybody put into a big bucket of less than 50. And this is what they found. Initially, they found that, of course, as you can see in red here are the hotspots, basically, which is areas that have higher incidence of mortality because of colorectal cancer. And so you can see that overall, there's a pocket exactly where we are here in the sort of bit of Midwest and also Northeast and also in the South. But if you take a look at the ones that that are younger than 35 years, it's mostly over here in the sort of Great Lakes region and here in the sort of Midwest, Northeast. So it seems like for whatever reason, people in these areas are getting and dying from colorectal cancer at a younger age, more so than the ones that are closer to 50 years. And then the opposite effect is seen more so on the western side of the country. So you can see that we're here in the California region, and then in the Southwest. So this is very interesting. And this is the first study that showed that actually here where we are in Cleveland is a hotspot for young-onset colorectal cancer. So why might these differences in mortality exist? And this comes to one of the questions in the audience earlier, like why are people getting colon cancer younger? So is that because of diet? Is it because of access to healthcare? Because of antibiotic use that could alter the microbiome? Or many other things that we're not thinking about. So the question that this study is now inviting us to do more research about is to see and evaluate these people or these pockets in particular and see what they have in different from the ones that have less incidence of young onset colorectal cancer, so we can provide more interventions to these patients. So that was one of the studies. Now going more onto the colonic polyposis of unknown etiology, and just to give you a little bit of a background about that. As we had previously said, it's okay if people have 1 or 2 polyps in their lifetime during colonoscopy on average age, as we recommend in higher than 45 years. We find them between 25 to 65%. Everybody's allowed to have 1 or 2 polyps. But then when throughout the lifetime they have more than 10 or more than 10 polyps, then we think, well, could that person just have a predisposition to develop more polyps, or could they be at high risk of getting colon cancer? So this condition called colonic polyposis of unknown etiology basically is defined as having 10 or more than 10 polyps throughout the lifetime, and then after undergoing genetic testing, nothing is found. So what is going on with these patients and how to treat them? Are they at risk, of course, high risk of getting colon cancer, but could they also be at risk of other malignancies like anything in the stomach, small bowel, or also the thyroid, for instance? As of now, the recommendation is that patients that have these conditions, CPUE, and more than 100 polyps or 100 polyps, they should be treated as if they had a condition called familial adenomatous polyposis. And we all know that people who have FAP are more likely to get other tumors, as I've just said, in the stomach, duodenum, and also thyroid nodules that become malignant. So the current recommendation is that all FAP patients should be screened for these things. But then, and of course the ones that have CPUE and also more than 100 polyps, but then if somebody has, let's say, 75 polyps, what should we do about them? Are they also at getting higher risk of either one of these thyroid conditions or also gastroduodenal conditions? So we didn't know much about it. As of now, the recommendations for the CPUE is that if somebody has that more than 100, they should get a yearly colonoscopy. They should get an upper endoscopy, taking a look at their esophagus, stomach, and also the duodenum, starting at age 20 to 25, and then also a baseline thyroid ultrasound. For those that have between 20 and 99 polyps, that they should get colonoscopy every 1 to 2 years, a baseline endoscopy at age 20 to 25, but there's really no recommendation about what to do with the thyroid. And then the ones that are have less polyps, so between 10 and 19, they should have a colonoscopy based on the polyp findings to think about maybe doing an EGD at 20 to 25, and there's really nothing about the thyroid. So based on all these questions and not having a lot of data on what to do thyroid-wise and also not knowing what to do with the upper endoscopy, then we wonder what can we do to exactly know how to better help these patients. So this study and this idea came up, this was led by Dr. Macaron, presented in DDW this year, which is a big gastroenterology meeting that just basically all of the gastro world goes and attends. And this is what we found. So we basically what we did is that we looked back and took a look at what happened and what did we find in all those patients that have had endoscopies. So they had taken a look at their stomachs and also their small bowel in the past years and seeing how many of those people had polyps. And that, of course, had more than 10 polyps in their lifetime. So we found that regardless of the amount of polyps that they had in their colon, these patients had either gastric, which is stomach, or duodenal polyps. So you can see most of them, so let's say from 10 to 19 polyps, 60% of those patients underwent endoscopy, and then 40% of those had gastric polyps. And then if you take a look at the duodenal polyps, about a third of them had them. And this is the lower count amount of polyps from 10 to 19. So based on this, we recommend that a baseline endoscopy starting age 20 to 25 in patients with more than 10 colorectal adenomas should be done. And then based on what we found in that first endoscopy, we'll decide when to do the next ones. Oops. And now what to do thyroid-wise. So we looked back at all the thyroid ultrasounds, and just to give you an idea, if, let's say, I could have a thyroid little nodule, the thyroid is somewhere here. I could have a nodule. If it's more than 1 centimeter, then that is more likely to become malignant. So those things need to be evaluated, usually taking a small needle to try to take some tissue and take a look at them. So those are the people that we want to catch. And what we looked and what we found is that none of the patients that had 10 to 19 polyps in their colon had big thyroid nodules. So based on this information, what we can recommend is that those patients who have higher than 20 polyps in their colon or throughout their lifetime should have a baseline thyroid ultrasound starting at age 20 to 25. And then if they have any thyroid nodules that are higher than 1 centimeter, they should get checked and evaluated. So this is just some more information about that. Now going back to the young-onset colorectal cancer. So we know that it's rising, and then we also know that about 1/5 of patients who have colon cancer before age 50 have an actionable pathogenic variant, which means there's something within their DNA that just predisposes them to have colorectal cancer. And what happens with this? Well, if somebody is found to have, let's say, FAP, then we'll know that they will need care, of course, for other organs that could also be affected. This information is also useful for family members. And then, of course, we want to do everything that we can in order to prevent cancer from happening. So knowing whether or not a person has a pathogenic variant is very important. And the better the path to get there is, of course, they need to be very well informed, and that's through our genetic counselors. So every person who is diagnosed with colon cancer before age 50 should have a meeting with a genetic counselor. But in reality, how good are we referring patients who are diagnosed at early age to genetic counseling and testing? So we look back at our data at Cleveland Clinic to see and to answer this question. This study was led by Dr. Liska and one of our internal medicine residents, Dr. Syed, who was also one of the lead investigators. And this is what we found. So they look at 791 patients that met the criteria, which met people who had had a diagnosis of colorectal cancer younger than 50. And we found that throughout the years, 61% of them were referred for genetic counselor. And only 80% of them actually completed the appointment. And of those, 96.6% completed the genetic testing. So if you look back, it's a little bit more than half of patients who actually ended up completing the genetic testing from all the patients. And from these ones that completed the genetic testing, 21%, which is about a fifth of patients, were found to have an actionable pathogenic variant. So the lives of those 21% of patients are actually changed, and we can help them out trying to prevent other sorts of cancers because this step was completed. So the investigators also looked at how have we changed throughout the years. So looking at whether or not patients have been referred for genetic counseling and whether or not they had actually completed it, and divided them through different brackets. So from 2010 to 2013, 2014 to 2016, and then in the past, 2017 to 2019. And if you take a look overall, things are getting better. So within 10 years, we changed from referring only 42.6% of patients to 73%, which is almost double, which is great. And if you take a look, the percentage of people who completed the test also went up. So of course, we would want to reach 100%, and that's our goal. So that's the hope, that things are getting better. Now moving on to more of a surgical aspect, I'll start by saying that people who have familial adenomatous polyposis of FAP have a 100% risk of getting colon cancer throughout their lifetimes. And the treatment for colon cancer prevention is basically removing their colon. There's multiple types of surgery to achieve this, and up to the 80s, the treatment of choice was to basically take out the colon, which is this one here, and attach the small bowel to the rectum, so the rectum was preserved. Then in the 80s, there was a different technique that came, which basically also removes the rectum and creates a little pouch or like a big pocket with the small bowel, and then it's just attached over here. This diagram represents sort of the old surgery that was done. With this old type of surgery, of course, you wonder, well, the rectum is part of the colon as well. So perhaps some of those patients ended up getting cancer in this bit of the colon. And that actually happened. So studies that date back to about 20 to 30 years ago showed that that risk was about 32% of cases, which is quite high, I have to say. The good thing about the surgery is that, of course, usually the rectum serves as like the stool container, so people are not having like continuous stooling. So that one of the benefits of this surgery is that actually patients would have more continence. They would not necessarily require a bag to be on their abdomen. But then the question now is, well, not that we know and we have better screening strategies, because of course if patients are left with the rectum here, then we'll have to take a look at the rectum continuously or throughout their lifetimes. But now that the screening and surveillance strategies are much better. Are we doing much better now with these patients than we did 30 years before? So the question was, if somebody has this kind of surgery in this era, what is the likelihood of them requiring this surgery to be removed, or let's say this bit of rectum to be removed after they have had this surgery, if that makes sense? So let's say I've got this surgery. What is the likelihood that I'll get cancer in this rectum left, or for whatever other reason it will need to be removed? So that was the big question. So what the authors did here, basically it was a team led by Dr. Liska, was to look back and see from 1993 to 2020, look at what happened with those patients. So they recruited about 197 patients, and they looked at, of all of those patients, only 6.1% required that rectum left to be removed. And it was because of various reasons. The most important one, because they had big polyps that harbor premalignant tumors, or because they had cancer. Very rarely because of other issues like having pelvic pain or issues with defecation, or because of leaks in the area where the small bowel was put back together with the rectum. So they also looked at what were the factors that were associated with requiring to remove the rectum. And the thing that was most likely and was more associated with it was actually having a lot of polyps. So they created this number, which is 20, or they looked at 20 was the number that if, let's say, somebody at their initial surgery had 60 polyps in the rectum, then they were more likely to, in the future, develop cancer there and then to have it removed afterwards. But these are very important findings because it shows that although initially we thought that perhaps leaving the rectum there was not a great idea, it actually could be a good idea for patients, particularly those who are very young, who have very low number of polyps in their rectum. And there's multiple other studies that our group has come up with and that they have not only within the Cleveland Clinic, but they have also collaborated with other centers around the world in order to make sure that we answer a lot of questions that we have to better provide care for our patients who have either young onset colorectal cancer or who have different polyposis syndromes. And there are also multiple studies that are ongoing, so please stay tuned and come back next year. And that's pretty much it. Thank you.
Thank you. Thank you, Lady Katherine. So the last speaker in our section will be, again, Dr. Carole Macaron, and she's going to talk about the active clinical trials that are ongoing at the Cleveland Clinic for some of these hereditary syndromes. Thank you.
So before I go over and review the active clinical trials at the clinic, I thought of spending a moment reviewing what clinical trials mean, the phases they go through, why it's important to get in. Dr. Schmit got into overall the importance of research. This is more into treatment trials and clinical trials. So clinical trials are research studies where patients or people volunteer to take part in. And it's a long process, takes several years. Usually the drug, the new treatment is tested in the lab, and then it's studied on animals. And if it shows promise, this is when it progresses to clinical trials or testing on a human. And there are 4 phases that clinical trials go through. When an individual volunteers to be in a trial, they're particularly in one phase of the study. Phase 1 studies focus on safety and the right way of administering the medication. It usually involves patients, like small group of patients, 15 to 50. Phase 2 trials are looking at the efficacy of the treatment and potential side effects from it. Usually less than 100 patients are included in phase 3 trial. Here we're comparing the new drug with the available treatment that we use now with the existing treatment. And then in phase 4, those are after the drug is approved and available. This is long-term, so thousands of patients are observed to look for long-term benefit and side effects. Not all clinical trials are right for all patients, and as Dr. Schmit mentioned, there's quite a bit of regulation that goes into that, and each clinical trial has its own protocol. And each protocol has strict rules that physicians must follow to decide who can get in the trial, join the trial or not. Those rules, we refer to them as eligibility criteria. Now, when you decide, if you want to enroll in a trial, you want to understand the benefits and the risk of each trial, and they're not the same for all clinical trials. So some of the benefits would be that the new treatment might be better than the available treatment, and if that's the case, you'll be the first one to benefit from it. You may also be able to help other patients or family members who share the same condition as you. And sometimes the trial sponsor may actually pay for some of your medical care and tests. Among the risk comes the side effect of the new treatment. A lot of the time we know about the treatment, we expect some of the side effects, but sometimes patients may experience side effects that we did not know about. New treatments are not always better than the standard treatment or the available treatment. Or sometimes if they work for other patients, they may not work for you who also enrolled in the trial. So it's important to ask all the questions you have until you get all the answers clear before you decide to enroll in a trial. So what do we have active now at the Cleveland Clinic? I'm going to start off with the encapsulated rapamycin trial, which is a chemoprevention trial in FAP. This trial is a phase 2 trial, so looking at the efficacy of rapamycin. We just completed it. The last patient had their endoscopy about a month ago. The rationale behind using rapamycin is that it blocks the mTOR pathway, which is a known pathway that controls cell proliferation, so cell multiplication and cell growth. By blocking that pathway, we hope that we could reduce cell growth and reduce polyp burden in patients with FAP. The trial was a 12-month trial. Patients took the medication. There are 3 different schedules. And they had a baseline endoscopy, a 6-month evaluation by endoscopy and colonoscopy, and then a 12-month exam. We will know the results of the study in the next few years. I know that the research group and the study sponsor are looking into doing a phase 3 trial, comparing it to placebo, but those are still under the development phase. The second trial is the obeticholic acid in FAP, often referred to as OCA. So OCA is a drug that is similar to bile acids that the body makes, but it's 100 times more potent. The way it works, it binds to a receptor called FXR on the lining of the intestines. And by doing that, it helps control DNA damage and cell proliferation, and then potentially reducing the risk of colon cancer. I'll show the graph in the next slide. Also, OCA is known to control bile acid production, so it can decrease inflammation and fibrosis, and it's approved and been used by our hepatology colleagues to treat some inflammatory conditions in the liver, such as primary biliary cholangitis. We don't know whether OCA works on reducing pulse in FAP, but this is what the trial is trying to look at. So this is the rationale behind the OCA. So it binds to that FXR receptor and controls intestinal stem cells, so less proliferation, less DNA damage, and perhaps prevent cancer. The OCA trial is a 6-month study. It's a randomized study where patients are going to be split into 2 groups randomly. Group 1 will go on the study drug, which is OCA 25 milligram a day. Group 2 will go on placebo. They'll have a baseline workup to make sure they can be enrolled in the study, and then baseline upper endoscopy and lower endoscopy, several blood tests in the meantime, and follow up virtually to follow up on toxicity, and then at 6 months we rescope. Upper exam and the lower exam. So who can be enrolled in OCA? Technically, all FAP patients who have either are gene positive, meaning they have a genotype, or clinically acting as FAP, and have either an intact colon, a rectum, or a pouch, and at least a certain degree of duodenal polyposis by stage 2 or 3. We have so far 2 patients enrolled in the trial. The exciting news is the Lynch vaccine trial. We talk a lot about chemoprevention trial in FAP, but this is the first Lynch syndrome prevention trial, and it is the largest one in the country. The idea behind this is not new. We have had vaccines before to help reduce cancer, like viral-induced cancer, such as the HPV vaccine, but this is the first one that is being done to a non-viral cancer. In Lynch syndrome, the genetic defect is in the DNA repair mechanism. So because we cannot repair those errors when the cells replicate, that leads often to an error in the DNA and subsequently translate into new protein. We call them neoantigen, or what I like to call a stranger protein. And those stranger protein will be recognized by the immune system, shown here in the red cell. It binds to the cell, eventually activate either by hormones, or actually end up killing the cancer cell. When cancer develops, obviously the system is no longer working, or it's overwhelmed by the amount of stranger cells. So what the Lynch vaccine is trying to do is to boost the immune system, to keep it always on the fence and looking for these stranger protein. It is a combination. So the way vaccine is, it's using an adenovirus vector, adding on it 3 common cancer or pre-cancer cell protein. And in addition to that, there is an immune boost given, the IL-15, to help raise the immune response to the vaccine. What we are hoping that by using the vaccine, we can prove that at 1 year and in 2 years, there will be a reduction in the occurrences of colorectal adenoma and cancer. It is a randomized trial. It's much more complex than this. I just left it to the last portion of the study, last portion of the randomization, where patients will be randomized to either a treatment group or a control group. In the treatment group, there is 3 series of vaccine at week 0, 4, and 8, and then there is a booster at 1 year. In addition to the vaccine, patients will be also receiving the N803, which is the IL-15 that I mentioned to help boost the immune system. The control group will receive a placebo vaccine and a booster at 52. And this is I'll show the schedule of event in a minute. Who can participate in the Lynch vaccine trial? So all MLH1, MSH2, EPCAM, and MSH6 Lynch syndrome who had at least 1 or more colorectal adenoma. For patients with PMS2 Lynch syndrome, a history of colorectal cancer is needed. And all patients should not have any active cancer in the past 6 months before enrollment in the trial. And this is the schedule of events. So at baseline, patients will receive a colonoscopy. At week 0, this is when they get the first set of vaccine. At week 4, week 8, and then a boost at week 52. First colonoscopy, first follow-up colonoscopy would be at 52, so at 1 year, and then another one at the end of the study, which is at 2 years. A last slide is on the use of neoadjuvant immunotherapy in rectal cancer. The PI here is Dr. Liska. This is a phase 1 study, so looking at the safety of using an immunotherapy in combination with standard treatment for locally advanced rectal cancer that is mismatch repair deficient, meaning lacking the DNA repair mechanism. So in addition to standard treatment, they get every 3 weeks an Keytruda injection. I do know from Dr. Liska there are 6 patients in this trial. If you have any other questions, he'll be more than happy to answer them. This is our research team. I tried to go over all the active research studies. I know, and we talked earlier, there are a lot underway. If you are interested in any of the studies I mentioned, please feel free to reach out to one of us. You may also hear from our research coordinator, Tara Schwenk, or from our research nurse, Michelle Dittrich, if we believe you meet the eligibility criteria for any of these trials.
Okay, that was a lot in a short period of time. We don't have a Q&A session, but Dr. Hurley is going to come. Did Karen come back? Oh, there's Dr. Hurley. We're going to have a patient panel, so this will be really important. But the rest of us will be around to answer any questions that you may have about trials and contacts. And of course, if you're interested in research, it's oftentimes the coordinators that say, oh, Mrs. So-and-so was in and said she would like to know more about the Lynch vaccine trial. So we actually will route that to our coordinating team and then be in contact with you if you're eligible. So Dr. Hurley, and we have a great patient panel.
Thank you so much. And while our patient panel is getting underway, I just wanted to put a personal face on the importance of clinical trials. I just passed my 12th anniversary of my diagnosis with stage 3 breast cancer, and I owe my existence to the women in the early 1990s who participated in the clinical trials for Herceptin. So they have my gratitude, and so thank you. As the other panelists said, that it's a highly personal decision based on what's right for you and in consultation with your doctor, but there is the potential to benefit people that you never see. Just in the interest of time, because I know that we want to get started, maybe we can start with, I'm going to add, this is something I sometimes will ask of patients when we're doing a therapy session, is to give me the headlines. So could you give us a headline of what it is that brings you here today, and also a headline about something that's true of you that is outside of cancer land for you?
Oh, wow, okay.
Well, my name is Jennifer Lapp. I am 41 years old, and I'm from Buffalo, New York. Go Bills, not really.
That's okay.
I am married, and I have a 11-year-old little girl, not so little, and I was diagnosed at 19 with FAP.
Is that good? Thank you.
My story is pretty long, so I'll give you the Reader's Digest version, but I was diagnosed at 19 after just having simple IBS symptoms, and I had a colonoscopy, and they saw thousands and thousands of precancerous polyps all over my colon, so I got genetically tested, and it turns out that I have FAP. This was very foreign to us because we never ever had this in our family, so it turned out that my gene mutated on its own. Fast forward a couple of years, I was diagnosed then with desmoid tumors. As they had said before in this process, that desmoid tumors can wreak just as much havoc on you as cancer, even though they're non-cancerous, and mine are in my mesenteric arteries. And in 2013, I had one wrapped around my SMA, so my superior mesenteric artery, and about a week before being fixed, it ruptured. I was in the vascular ICU, thank goodness, and I spent a good amount of time there, over a month, and it was very difficult. My daughter at that time was 1.5 years, and it was challenging. But since then, I'm still sort of dealing with the aftermath that FAP as well as desmoids have kind of caused me, but I'm thankful to be here, and I really do appreciate, everyone having a panel like us on here, just because I think it's so important for our patients to hear that you're not alone, and that my story might be different than their story, regardless of what type of genetic disorder you have, but you still are able to, take it day by day, and you can still stand. So, sorry, that was a little.
No. Thank you so much, because that really, illustrates like the tremendous ups and downs of the journey, right? And journey is sometimes a mild word for what it's actually like to go through it, but it's also a reminder of how individual everyone's story is. So if we could go to our next person.
My name is Sheila Schrack. I'm a Ravens fan. Sorry about that. We'll still be friends. I actually just turned 56 years old, but I was diagnosed at 38 with colon cancer. So I'm super excited to have had a birthday at 56. I was really pleased. I had my all my work done here at the Cleveland Clinic, and I was in a clinical trial. So I love to be the poster child for Cleveland Clinic, to be quite honest with you. I have a grandson. Both my kids got married. Okay.
Thank you so much. Yeah.
Hi, my name is Pam Hill. I'm 59, and I'm a proud mother of 5 girls and 2 grandsons. And I was diagnosed with Lynch syndrome, specifically PMS2, and stage 3 colon cancer, and surprisingly, stage 1A endometrial cancer. And I had surgery with Dr. Liska a year ago, 2 days ago. And I just completed chemotherapy in April. So,
wow. So, yeah. Thank you. That gets an extra thank you for getting out of bed and joining us.
Yes.
Right? Yeah. But also, I love hearing how much connection and family is worked into like what it is that brings you here. So I'm really glad that you brought that forward. So let's talk a little bit about one thing that you wish you had known somewhere along the way, and sometimes that's at the start, when you're getting a diagnosis, but really let's make it open. Pick one thing that you wish you had known somewhere along the way that would benefit, the people who are your treatment team.
Well, I think for myself, knowing, one, that you're not alone. When we were first starting this journey, like I said before, there was no history, prior history. So I didn't know what was coming. You know, I went for a routine colonoscopy and I thought, you know, I'm here with a bunch of 80-year-olds, you know, and it turned out that, you know, 3 weeks later, I was getting a major surgery at 19 years old. And so I think for me, knowing that, yes, you can heal from all of your wounds. You can, you know, go through the chemotherapy like I had. I can be, look physically fine, but internally, a lot of us are going through our own battle. And I think that patients should know that they're not alone and that your mental health is probably just as important as your physical health, and that you are, it's not a stigma to seek help when you're going through all the traumas that this type of disease, you know, hereditary colorectal cancer can bring, and that it is something that can further you in your recovery from all of, you know, that you're going through.
Yeah, thank you for that. And, you know, it's such an important reminder. And also, you must have read ahead on the third question, because it was going to be about saying something that really encourages others. And that's the fact of not being alone and reducing that sense of isolation is so important to mental health.
I agree. I think too, you have to learn to advocate for yourself. If you don't feel right and your body doesn't feel right, even though somebody may have told you, I was misdiagnosed the first time, just keep fighting, keep telling people that you don't feel good. Like it's your body, you know it best. And the other thing is get a community. I didn't find, my husband and I advocate with Fight CRC, and I didn't find until after my diagnosis, but they're your people. They get you, you know, like you're in your own club. I tell people I'm in a club now that nobody wants to be in, but I'm in it, and I need those people that are going to lift me up. I have my family and they're amazing, but I need people like you guys too.
Yeah.
Oh yeah, most definitely. You know, in fact, and this is a different way in which you're not alone, is sometimes, you know, cycling through several different doctors to get that diagnosis. There is unfortunately a word for it because it happens often enough, or a phrase, diagnostic odyssey. And that's definitely something I hear when I'm talking with patients.
I think too, though, you have, going along with being your own advocate, you, especially if it's coming from a hereditary standpoint, you have to almost be an expert in your disease, because you don't necessarily know where to go, which doctors to see, which protocols are available to you. You have to really do the research. And I know that, when I'm 41 now, so a while ago, we literally took around a binder and we were able to put in all the research that we had, or all of the doctors, information that we had, just so we can kind of review it so that we knew what the next steps were. When you have a plan, I think that it's a lot easier for you to kind of face, what is about to happen to you, and you're not so blindsided by it.
Okay, great. And how about you?
I wish I'd known how fast it would happen.
Oh, yeah.
It just, at the time, it seems like just everything slows down. everything's swirling around you, and you're just in the eye of a storm. That's what I think of. And eventually, like if I knew now, like I can look back now, hindsight's always better, but it just happened so fast. But that also that eventually I would understand the words that were being spoken, just how quickly, I just am amazed. And we all in our homes sometimes will look at each other and say, did that happen? So.
Very much so. So I'm really curious, what would you say to someone else who was just at that very beginning, like they were right in the eye? What would be the encouraging words hang on?
It just hang on. There were times that I would look at my husband and say, I don't know if I can do this. Mainly through chemo. Yes. I was so prepared, well prepared by Dr. Liska and Christina for surgery. I had all the printouts, we blew them up, put them on the walls, the food list, those were wonderful. What I wasn't, and I think it's just an unknown how chemo is going to affect someone. So that's when it got dark sometimes,
Yeah.
And just hang on. I think that it's just if you can just show up, just keep doing it, keep plugging away, and eventually you'll be on the other side. I promise.
You beat today, so you can definitely beat tomorrow.
Right. Sometimes it's one day at a time. Sometimes it's 1 hour at a time, right?
Yes.
Yeah, definitely. So for each of you, and we kind of probably know the answer already just listening to you, but can you pick something that you would say that you're most proud of in getting through what cancer has put on your plate?
I think for me, I'm most proud of my resilience. I've obviously dealt with this for many, many years, and I now have to face the fact that my daughter might have this disease. We have yet to test her. Like I said before, she's 11, so she's kind of in that in-between, and she hasn't exhibiting symptoms yet. But, I think that, like you had said, you just have to hang on, and I think that I'm pretty resilient in the sense of, my positivity, because I know that, someone could always have it worse, and I'm thankful for what I have in the family support that I have. So I think that, knowing that it's dark right now, but it won't be dark all the time.
Yes.
Yeah, absolutely. And sometimes that's hard to get across, right?
Sure.
Yeah. And how about you? What would you say?
So I'm an advocate early on that told me to turn my pain into purpose.
Okay.
And that's what I'm most proud of. I'm most proud of my husband, who walked across the country to raise money for fight colorectal cancer. He's hiked Kilimanjaro. We've jumped in lakes. He kayaked the Mississippi this summer. So we don't want any other family to feel this way. And we will do whatever it takes.
Yeah. Thank you so much.
I would say my family.
Your family,
I think that cancer, I was the carrier of the cancer, but my entire family had cancer. They walked through every single moment with me. And sometimes better, they carried me through it, so they just were amazing. I owe them so much, so.
Yeah, and that's so true because, sometimes family members will pressure themselves to be the rock or to keep their problems off to the side, but they're right in there having their own experience from a different angle, but the same stress.
I don't
Absolutely.
think we talk about our caregivers enough as far as what they go through as well. We, get the brunt of it, the surgeries, the chemo, the pain, but they have to watch a loved one go through what we're going through, and I think that they mentally need as much support as we do in certain times. No one asked them to go and stand by us. Just like we didn't ask for what we were given, we just have to kind of do it.
I also wish that I would have. My kids are 31 and 26 now. They were in 1st and 6th grade when I was diagnosed. That I would have looked at their mental health. But I was diagnosed in 2006, and honestly, we just weren't talking about mental health like right now. But I definitely, I try to share that with families. Please, let somebody talk to your kids. Again, they're like, oh, we'll take it. We'll be okay for mom. We'll be okay. But that's something I wish that I would like to share with people. Definitely make sure your kids are okay.
Yeah, that's really good. Any other thoughts from you? Yeah.
I have 2 daughters that were also tested. All of the daughters were tested. 2 were tested positive for Lynch syndrome, PMS2 also. They inherited it from me. So they got to see firsthand just how lucky we are to be here. I'm so thankful, they don't have to worry about if something happens in the future. I don't have to worry. I know that, these physicians can tackle anything. So it really is. I love that they had the Weiss Center before I knew what it was. So.
Exactly. Yeah. And that's really the beauty of genetic testing at its best. I see Dr. Burke. Is that a time checker or a question?
I have a question.
Yes, let's please.
So one thing that I took out of my slide set is
when some of the, now fourth generation I take care of see what their grandparents went through or their parents went through, they are devastated. And it's important to know that not everyone with the same gene variant has the same course of disease. So
Yes.
colon polyps, yes, but not everyone that, if your mother had colon cancer at the age of 38, that you're gonna have it, right? So I think dispelling the myth is, oh, you know what, I look just like my mom, I'm gonna have exactly the same thing. So I want to dispel that myth to a large percentage.
Tell me whether this resonates with you. That moment when you get the shock of the diagnosis, and people react differently, but sometimes people feel like they were in a movie or it's happening to someone else. It wasn't real, right? Or you just don't hear it, you're not processing it. That's like the mental airbag that inflates because your brain is just saying that's too much, right? And so in some ways, there may be, what we have to do is to help people kind of deflate the airbag and then give them a chance to come back and somehow hear it again, hear it differently, and involving patients in that process and advocates is an amazing idea. Yeah, thanks. How are we on time and process? We should wrap up. Okay, thank you guys so much. You just went to the heart so quickly, and I'm really glad you were here.
Thank you.
Thanks.
So thank you, everyone. Thank you, Dr. Hurley, and thank you to our patient panel. That was really, really powerful way to end the day. And really, whenever we have patients talk to us, that's when we as physicians learn the most. It's really reminds us of why we went into this to begin with, is when we listen to our patients and hear their stories, not so much hearing them talk about their symptoms or hearing how they're doing with their diseases, but hearing about what they're going through on a personal level. It really drives home why we're in this to begin with. So thank you all, and I would also like to thank everybody who joined us online and virtually, and thank you for everyone who submitted questions. We do have surveys that are going to go out by email, Lisa, or?
Yeah, by email to all the online participants.
By email to all the online participants, and I think everybody who came here in person got a survey to fill out just right now, just to tell us what we should do differently for the next year's Education Day, what worked well, what we should bring back again. So please, if you can take the time to do that. So again, I want to thank everyone for joining us today. This is one of the highlights of the year for us, to be able to do this Education Day and explain everything that we are doing and hear from our patients how we can do better. So thank you all, and we will have, thanks to the AV team for helping with this, we will have this on the website. And for patients who couldn't make it today to watch, and for anybody who wants to catch up on some of the other things to watch it again. So thanks again, everyone.
I just want to thank Sarah Macaron for all of her hard work in putting this event together. It wasn't easy, and she
Thank you, Lisa, too. Don't sell yourself short. Thank you, Sarah. Thank you, Lisa. Thank you, all the coordinators, not just for today, but for everything you do all year long. We wouldn't be here without you guys.